Hello? Yes. Good afternoon, everyone, and thank you for coming today. I'm Lynn Kerwin. I'm a trustee of the Foundation and the voluntary chief executive. As you know, our charity exists to raise awareness of Hughes and to support those who are affected by the condition. Since, like many small charities, we have no government funding, our work is made possible by the support of you, our members, and the marvellous volunteers who fundraise on our behalf. I'm thirsty, excuse me. We can't thank you enough for your support. The last year has been a wonderful one for the Foundation. Baroness Estelle Morris agreed to be our chair and will undoubtedly bring in invaluable weight and profile to the charity. And it's very encouraging that the awareness of Hughes is growing all the time. You will find it under antiphospholipid syndrome on many of the key websites, including patient.co.uk, which is a site which most GPs use. We've even made it to the Collins English Dictionary. Our principal objective at the moment is to help GPs recognise and diagnose the condition. As many of you will know from experience, they do need help because the symptoms are so varied. To that end, Kate has been successful in securing grants for a new website and a campaign to raise awareness amongst GPs. We hope to have the website finished by the autumn, and it's intended to give clear and comprehensive information on all aspects of Hughes, which will help both you and your doctor. I must congratulate Kate on organising a marvellous programme today and to thank the distinguished speakers who have given very valuable time to be here. As we were coming in, I asked Graham what was a collective noun for professors, and he said, an absence. Well, they're all here today, and I'd like to introduce Graham Hughes, who made all of this possible. Thank you very much.
Thank you very much for those words, and thank you all for coming. Well, the title is a bit odd, isn't it? The brain is stupid. But I'm going to talk about some of the features that we see with this syndrome, and I'm sure there'll be questions to ask afterwards. So, before I start, I just wanted to make clear that although there's an overlap between lupus and Hughes syndrome, or antiphospholipid syndrome, this Venn diagram shows what we believe, that about 1 in 5 lupus patients have got sticky blood, but by far the majority, we think, of patients don't have lupus. And I've purposefully put the right-hand bubble bigger than the left, because I really do believe that as neurologists and cardiologists, obstetric doctors start diagnosing more of this, that it will grow as lupus did 40 years ago. So we've got to start with the Rolls Royce. This is a case of diplomatic epilepsy. And this lady is the wife of a senior American diplomat. She came to live in London, posted here, obviously with her husband, the diplomat. She developed a rash at the age of 25 and joint pains, and they diagnosed in America mild lupus. She had positive DNA, not very strong, and the lupus was not a major problem. She treated with Plaquenil. But she did have high levels of the sticky blood antibody called ACL. Her main problem was not lupus, but epilepsy. From the age of 15 right up to her present age 50, severe epilepsy. She's under the care of Queen Square Hospital. She required no less than 5 different anti-epileptic drugs. She came to London and soon after arrival had a deep vein thrombosis, started on warfarin, and what happened? Immediate improvement in the epilepsy. She's now controlled on 1 anti-epileptic drug only. So what's this patient teaching us? We think that epilepsy in all its forms, temporal lobe, absences, déjà vus, and so on, are associated with the antiphospholipid syndrome. Many years ago, Charles Mackworth Young, who was my registrar at the time, found that epilepsy in lupus was associated with this antibody. But a very interesting study has come from Italy, where Dr. Simaz looked at teenagers with, inverted commas, idiopathic epilepsy. That's epilepsy without a known cause, like a head injury. And 28% were positive for antiphospholipid antibodies. So that's just an introduction to show that the overlap with many specialties. Now, it's 29 years ago since the syndrome we published in 2 British journals, The Lancet and the British Medical Journal. And the syndrome we called thrombosis abortion, and you'll be hearing today from experts in the major problem of recurrent pregnancy loss. But I wanted to highlight this slide because it shows cerebral disease. The brain and the placenta are the 2 organs that just seem to be targeted. So it's not lupus. Most patients with antiphospholipid syndrome do not have lupus. I believe on this television series they've now had a case of antiphospholipid syndrome in this doctor program. So what do we look for? We look for the skin, because some patients have cold circulation. The mottled, this is a very gross example, and we call it livido. And one of my patients calls it corned beef skin, because it's got that funny look about it. But it's, for us as detectives, it's a very, very useful sign. But my 10 minutes is to talk about the brain and some of the features. And if you want to snooze gently, every part of the brain can be involved, and this is something of a list. The 2 commonest manifestations are memory loss and headache, migraine. And this is a major problem. We see this 5 times a day in our clinics. A major feature, it often starts in teenage, often goes away and then comes back. It's often familial, actually. It's quite interesting. It runs sometimes in families. And if that patient gets a DVT or another reason to go on an anticoagulant, the headaches often disappear. And interestingly, in pregnancy, when a young lady is on heparin for 8 or 9 months, they often have very few headaches during that whole period. So it's clearly related to stickiness in some way of the blood. Just to make a point here, that migraine is a very expensive commodity. I got this figure a few years ago. In the United States, $17 billion a year cost of migraine. And there are rare case reports of migraine patients having a stroke. And I think, and I stick my neck out, that the missing link in these rare patients is the antiphospholipid syndrome. What do you look for? We do the brain scan, and what we look for is small white dots. Now, on the left, I haven't got a pointer, but you can see 2 little dots, and on the right, 3 little ones. And we believe that these are small areas of sludging of the blood, microinfarcts, if you like. And although the MRI has limitations, it's still the best and most expensive, of course, test for this condition. And in fact, it's very, very striking. This figure comes from Rome, where they did a study looking at stroke in a large neurology clinic. And guess what? 1 in 5 of all strokes, young strokes, that is, they defined it as 45, were positive. Now, we've been trying to persuade the government as a charity to take note of this, because they have a big screening thing for stroke now, and you've seen the television adverts. But they weren't interested, unfortunately. We won't give up, because this is so cost-effective to prevent stroke in a patient with antiphospholipid. There are many other features. Movement disorders. Some people get tics or jerkiness. Some very rarely get the full-blown movement disorder of St. Vitus dance. And there are a few cases of Parkinson-like tremor. One of the common things is giddiness. It'd be interesting to put up your hands, those who are patients, to say how many of you here have a tendency to balance problems. Maybe you could put up your hands as an army. And there's a very good balance doctor in London, Peter Savundra, who is expert in balance, and he's sending me patient after patient who presented with Meniere's or one of those things. One of the big question marks is some of our patients are labelled as possible multiple sclerosis. And this, of course, is a major anxiety, because some of the cases are missed antiphospholipid syndrome. This charity, many of you were involved in this, did a little audit some years ago, and we asked all the patients attending the lupus clinic at St. Thomas's, did your doctor at any time mention a possible diagnosis of MS? Guess what? 1/3 of antiphospholipid antibody positives had had this terrible diagnosis hanging over them, compared with 8% of lupus clinic controls. Sleep. This is another factor. And I've listed here, it's a long list, but it's less frequently recognized, but maybe very common features. Sleep disturbance. We've had a number of people with odd sleep patterns, going right through to this thing, I've forgotten the name of it, where you sleep not only in lectures but during the day. And temporal lobe epilepsy, these funny feelings of absence or déjà vu, where you feel and it's an exaggerated of the norm. I put autism here because we have some families with antiphospholipid in the family and autism. I put it as a question because we've not done a survey, but I bet money that there is a link in some cases. Sensitivity to food, but particularly to alcohol. Some patients, particularly problems with things like wine, and they get severe headaches, they're in trouble, and it's something that seems to come out. Peripheral neuropathy is pins and needles in the feet and hands. Not common in other diseases like lupus, but quite common in our patients. Sometimes pins and needles on the face is trigeminal neuralgia, we call it. The big one, of course, is memory loss. And every one of my patients says memory is a problem. I'm the joke of the family. I really couldn't remember. I had to start writing everything down. One of my patients, one of my earliest patients, couldn't remember which exit from the roundabout when she took her children to school. It was that sort of severe memory problems. Another of my patients, I've mentioned this lady before, she was the darts champion of her village, and suddenly she couldn't recognize where the 20 was. So these are bizarre focal wiring problems, obviously. There may be psychiatry things as well. Memory loss, probably some patients are already worried about Alzheimer's disease, which this is not. OCD, that's compulsive disorder. We have a couple of patients with that and have improved dramatically with anticoagulation. And last of all, fear of flying. Now, this is a hobby horse of mine, because I really believe this. Maybe I have a hands up thing here as well. Some of my patients, after a long-haul flight, are in big trouble. They are unwell for days, not just jet lag. If you go to, say, Washington or United States, for 2 to 3 days, headaches, not quite with it, balance, and so on. And I wonder if this is a real thing. How many patients do get this, what they think to be an exaggerated problem? Yeah. One of my patients' husbands is a BA pilot, and I asked him, is this possible? He said, it is, because the pressure in the cabin is about 5,000 feet. It's not ground pressure, and it's kept there by the strength of the engine. And when he's at 40,000 feet and starting his descent, he pulls back the engine considerably, obviously. And for about 10 to 15,000 feet, you are relatively hypoxic in the cabin. So the brain is stupid. If it doesn't get enough oxygen, it reacts in all these different ways. Finally, what about treatment? You'll be hearing much more in a minute from my colleagues, but we're still limited very much in drugs. We have 3 drugs. None of them is registered for. I had to fill in forms today for a patient with antiphospholipid, just because the heparin we were giving is not registered. But aspirin, heparin, and warfarin. I should say that they work in different ways, which you'll be hearing about, I think, from Dr. Beverley Hunt as well. Aspirin, yes, but for those who are sensitive to aspirin, we use clopidogrel or Plavix, which I call expensive aspirin, but it's a very useful drug in our clinic. But what about heparin? Heparin, the Americans use old-fashioned heparin because of cost, but we've been lucky in this country having low molecular weight heparin, which is pure and very rare to have any side effects except bruising at the site. The downside, it has to be given by a mini injection. But it's used in all clinics throughout the country for anyone with a thrombosis as first-line treatment. But in some of our patients, it has a very dramatic effect. And if we have a patient on aspirin but doing very badly, increasing headaches, balance problems, I always use a 2 to 3 weeks, sometimes more, course of heparin. The patient goes away, self-injection for a fortnight, comes back, how are you? And the answer may be rubbish, no good, or fantastic. I really felt the cloud lifting and I was sharper. And just to prove it, here's a study that was done a few years ago by Dr. Burdani. He was a psychiatry registrar and he was attached to our clinic for a year. And he was doing fancy memory tests. And on the left, this girl, normal IQ, but she couldn't string words together. She couldn't remember words, 13th percentile. 4 weeks of heparin, right up there on the 84th. And that just supports what the patients sort of tell us. Finally, warfarin. I'm afraid that's the drug that we have until something magic comes along, like the new anticoagulants, which you'll be hearing about. I believe that in many, many cases, the treatment of the brain is the disease is under treatment. And here's a made-up example. The surgery, High Street, and this is a letter to me. Dear doctor, Mrs. Jones is still suffering severe headaches and ataxia despite warfarin treatment. First thing you do, look at her little book, the INR. And this is made up, but in December 2.9, January 2.7, 2.1, 2.4, 2.3. Useless. No use. It's like treating a diabetic child with half the dose of insulin, wasting the time and doing harm. And it's a finding in all our patients that the INR has got to be correct for that patient. And this old cartoon, which we shows an INR in this patient at 3, which seems to be okay. But when it falls to 2.5, back come the fog, back comes the headaches. So just to reinforce, in the brain, the problem is clotting or sludging, if you like, of the blood and not a bleeding. And the neurology world, sadly, still worries more about bleeding on warfarin than clotting in these patients. So in conclusion, the brain is very sensitive to circulation loss. It's going to be a major chapter in neurology textbooks one day. All aspects of neurology are seen. Certainly the diagnosis, many of you here will testify, the diagnosis is often missed early on. And if you get the treatment right, the result can be absolutely dramatic. We've seen overnight improvement in patients with cerebral Hughes syndrome. But I want to end with bad news, and that is, this is a survey done by Kate and the team in the charity, and some of you here took part in this. This was a YouGov survey of 2,000 adults. Which of the following have you heard of? Hughes syndrome, 4%, antiphospholipid syndrome, 2%. More had heard of lupus, but still not great. Rheumatoid, 90%. And I think it's the job of our charity, as well as every single person here, to try and raise information about the antiphospholipid syndrome, to teach doctors as well as government officials, as well as patients about it. And to avoid this sort of headline, such as appeared a few weeks ago. Girl, 15, 2 strokes after going on the pill. We know her, she was antiphospholipid positive. Thank you very much. I think if there are burning questions, if you wouldn't mind keeping them just to the end. We're going to have question and answer session at the end with all the speakers. We have a website, many of you know it, and we have a blog every month called Patient of the Month, which tells us about one particular patient. But I would like to advertise a book that I've written about the discovery of it, and the proceeds of this going to the charity. And I've put lots of adverts at the back for it, so it's light reading. I'd like to welcome the next speaker, who's a very old friend. He's the chief lupus doctor now in UCH hospital, and a great friend. He's coming back here in 3 weeks or 4 weeks' time to talk in our postgraduate program. And he's leading a lot of very good research in antiphospholipid syndrome. Welcome.
Thanks very much, Graham, and thanks very much for the invitation. It's my second year here. I came last year, and they invited me back, so something must have gone right. I have to correct something first. I'm not the chief lupus doctor at UCH, in fact. The chief lupus doctor at UCH is a man called David Eisenberg. The reason I make that correction is if I don't, I may be shot when I go back. Another thing I'd like to mention is, you notice that Graham put up a picture of House. I've seen House lots of times. I'm sure lots of you have as well. House is the cleverest doctor in America. Terrible patient manner, but really good at medicine. The episode of House which Graham describes was referred to in a big American meeting. And they actually showed a clip from House, and it goes like this. House, at the end of the episode, finally gets the diagnosis, and he says, I think it's antiphospholipid syndrome. And his acolyte says, are you sure, Dr. House? And House says, no. And the point of it is, antiphospholipid syndrome is so complicated, even House can't make the diagnosis half the time. So why is it so complicated? And part of the reason is about what Graham said in his talk. Back in the very beginning, when Graham and his colleagues published that paper in 1983, when I was just a child, he said it was about clotting and miscarriages. That was what it was about. But now, did you see all those other things that can occur in people with antiphospholipid syndrome? Some of those things which have no real connection to clotting at all. So this syndrome causes many, many other things. You cannot explain this syndrome just on the basis of the blood getting thick and sticky. Other things must be going on. And the purpose of my talk is to show you how people are trying to look into that. People all over the world now are trying to look into it. There's a very thriving antiphospholipid syndrome research community. In fact, Munther Khamashta is going to talk to you about a group called APS Action later on, which is a kind of alliance of people from all over the world who are interested in this and are looking into this. So we're interested in what's actually going on and how you can lead to better treatments by that. Now, I don't have any slides. What I have are 3 teacups. Now, the purpose of these 3 teacups is to illustrate something for you. Antiphospholipid syndrome is one of the autoimmune rheumatic diseases, by which I mean it's where your immune system goes wrong, makes antibodies which attack your body, causing problems. That's what this syndrome is. The antibodies involved are called antiphospholipid antibodies. Now, there are other syndromes just like that. Rheumatoid arthritis is one of them, and lupus is one of them. And basically, in the management of these syndromes, it goes through 3 stages, which are represented by the 3 teacups. The first stage, the most backward stage, if you like, is where you're treating patients with a drug that you just happened to found that it worked. It wasn't that you worked it out by doing experiments, it happened to work. So, for example, that's like steroids for lupus and like warfarin for the antiphospholipid syndrome. Warfarin is used for all sorts of things apart from this syndrome. Thins the blood, stops it clotting, and it works. Many of you will be on it. I don't want to denigrate it or run it down in any way. It has saved people's lives. It has saved people from strokes. It does very good things, but it can also have side effects. So that's your first stage. You're not quite sure what's going on, but we have a treatment which seems to work. That's the best we can do at the moment. The second stage, that's the middle teacup. In the second stage, what you've done is you've done biological experiments in the laboratory, and you've worked out, you think, what's going on in the disease. By doing that, you can design drugs which target that disease. So now this is clever. This is thinking about what's going on in the disease. But you can't use them yet in patients because first you have to do trials. You have to prove that they work. You have to prove that they're safe. So that stage is where we are with lupus at the moment, because with lupus, there is lots of research being done. There are lots of new types of drug which are in trials. Some of them work, some of them don't work, but they haven't been brought into general use yet because they're still in the trial phase. And then the third stage, the most advanced stage, that teacup there, is where the trials have been done, and you know which ones work, and you know which ones don't work, and now you can bring in these new exciting drugs into the clinic, treat real patients with them routinely. And this is where we are with rheumatoid arthritis. So rheumatoid arthritis 10 years ago was where the second teacup is, and now, if you know somebody with rheumatoid arthritis, they may be on one of these new drugs which are called biologics. They're expensive, they're clever, and they're very, very good. So that's the APS teacup. That's the lupus teacup. That's the rheumatoid arthritis teacup. We want to move the APS teacup to there. Actually, I'm being a little bit unfair. Last year I came here and I said the APS was back there. Now it's somewhere between the first and the second teacup because there are trials now of new drugs, and I think Beverley Hughes is going to talk about some new anticoagulants which are in that trial phase. So things are moving ahead. But what we want is to understand more about what's happening in this disease so you can design and trial these new treatments. So what is happening in this disease? So I said the disease is caused by antibodies. What do antibodies do? Well, antibodies are a bit like magic bullets. What they do is they recognize things. They recognize very, very specific things. If you've had a vaccination, say, against diphtheria or tetanus, it means your body makes antibodies which recognize the diphtheria and tetanus. Whenever that comes into the body, the antibodies go and hit it and take it out, so you can't get those diseases. That's what antibodies do. They recognize things and cause an attack. The antibodies in the syndromes I'm talking about recognize something that you shouldn't really be recognizing, something which is part of your body all the time. You don't want to be attacking that thing, and yet your body is making the antibodies which attack that thing. So you can see that the key to understanding what's happening in antiphospholipid syndrome is to understand what those antibodies are attacking. What is it that they're attacking, which they shouldn't attack? How can we stop that from happening? Or, if we can't stop it from happening, how can we stop it leading to terrible consequences? So now we know, in general, what things are being attacked. Now, although this syndrome is called antiphospholipid syndrome, and phospholipids are part of your cell membrane, they're fatty molecules, as a matter of fact, it turns out that the main thing the antibodies bind is not really phospholipids. It's a molecule which hangs out with phospholipids, which binds to phospholipids in the bloodstream and on cells. And this molecule is called beta-2 glycoprotein 1. That's the name of it. Beta-2 glycoprotein 1. I'm going to shorten it to beta-2 just for the purpose of this lecture. We all have beta-2. It's in all of our bodies all of the time. Everybody has it. It's completely normal. We don't really know exactly what it does, what it's there for. It could do a lot of things, but for example, they have bred mice which have no beta-2 at all, and they seem to be perfectly healthy. They manage without it. So we don't know exactly what it's there for most of the time, but we know it's there in everybody. We know that it's the target of most antiphospholipid antibodies, not all of them, but most. And we know that because in a famous experiment done in Sydney, Australia, about 20 years ago, they took two groups of patients. One group of patients had antiphospholipid syndrome, so they had thrombosis and so on. The other group of patients tested positive for the antibodies, but they didn't have a syndrome. Nothing was happening to them. The antibodies in those patients were somehow harmless. They tested the antibodies from both groups of patients to find out what was different. And what was different was that the antibodies from the people who had the syndrome bound to beta-2. They recognized beta-2, and the harmless antibodies, which didn't do any harm to anybody, didn't bind beta-2, and that was the first clue. And since then, lots and lots of people have shown the same thing. So we need to understand a bit about beta-2. I'll describe beta-2 to you. I want you to imagine a hook, a J-shaped hook, like that, okay? And I want you to imagine on that hook, I've threaded 5 beads, so a hook with 5 beads on it. That's what beta-2 looks like, a hook with 5 beads on it. The beads are called domains. They're part of the protein. One domain, domain 1, which is at the stem of the J, right up at the top there, that is the bit of beta-2 GP1 which the antibodies attack. We know that from lots of different experiments. So here's the thing. How can we take advantage of that knowledge? If we know that the key thing going on is when the antibodies attack domain 1, what are we going to do about it? 2 things that we can do about it, and these are things which my group at UCH, where incidentally I'm not the chief lupus doctor, I want to remind you about that, my group at UCH are looking at this. So domain 1. Number 1, we can make domain 1 by itself. We invented a way to get bacteria, bugs in a culture disc, which make beta-2 for you. Lots and lots of beta-2. So why do you, sorry, not beta-2, domain 1, just the domain at the end. So why would we want to do that? Why would we want to make domain 1 in a bacteria? Well, there are several reasons. One reason is, if you imagine somebody's blood with lots of antibodies around trying to attack beta-2, okay? They're trying to latch on to beta-2 at its domain 1 end. How could I stop that from happening? Well, suppose I give that patient lots and lots and lots of domain 1 by itself. The antibodies will take that instead. They'll prefer to take that rather than the whole beta-2. It's called competitive inhibition, if you like. So if you imagine, for example, that you have a football manager and he has some players who he wants to buy, and all of a sudden a very, very good football player comes along, he goes off with him instead. That's what domain 1 is like. We give domain 1, it removes the antibodies and stops them from doing any harm. That's the theory. Does it work? Well, there are lots of steps to proving whether it works or not. First, you've got to make it, so we've made it. Then, you've got to show that it stops the antibodies from binding to beta-2. And we've done that as well. There's a way in the laboratory of proving that, and we've proved it using samples from patients. And then you've got to try it out in experimental animals. And there are people in America who have a mouse which can get clots when you give it these antibodies. When you give the mouse the antibodies, but you give them the domain 1 that we made as well, it stops them having the clots. So that's only been done in a very small experiment so far, but it's very encouraging. So as part of our research program, we're trying to make this domain 1 in a way that it could be used as a drug. I won't go into the details of how that would be done yet, but that's one of our aims, to make a completely new drug based on domain 1. The other thing you can do is use domain 1 in the form of a test. So currently, if you want to test people for antiphospholipid syndrome, there are 3 different tests that you can use. You may have had these: anticardiolipin, lupus anticoagulant, and anti-beta-2. Those are the 3 tests. So let's suppose you had a test which just picked out anti-domain 1. Well, that might be a better test. It might be a more accurate test for seeing who was going to get antiphospholipid syndrome and who wasn't. In particular, there are some people who have the antibodies who haven't got ill yet. They haven't got a thrombosis yet. They haven't got a miscarriage or something yet. They might in the future, and then they might not. How do we know whether they are going to or not? Clearly, the patient wants to know. If you've got a better, more accurate test, that might be helpful. And maybe the anti-domain 1 test will be a better and more accurate test. Now, that's not the only test in the game. There are other people in other units working on different tests. This is not the only one. But what I would say is it's very likely that a combination of the work by lots of people all over the world will lead to a generation of new tests in the next 10 or 20 years, so you can be much more accurate in the advice that you give to patients. How are we going to work out which are the best tests? Well, the big thing is you have to test samples from real patients. You have to have patients who you know what happened to them, whether they had thrombosis, whether they had miscarriage and so on, and you test them in your test to see how accurate it is. If I have a test which 100% of antiphospholipid syndrome patients test positive, but 90% of healthy people also test positive, well, that's not going to be very much use to me, because if it's positive, I don't know what it means. If I have a test which 80% of patients are positive and 0% of healthy people are positive, that's very useful to me. But how are we going to get that information? Only by testing the blood of people with the syndrome. And actually, that's the place where we are now. We need to test the blood of lots of people with the syndrome. That's why I'm working with Munther and Graham and with Lesley Regan, who I've just seen come in from St Mary's, and I'm trying to get samples of blood from patients so we can test it. So at some point in the future, if somebody in the clinic asks you if you would donate blood for such a project, I hope you'll think about doing it, because that will help us to get to where we want to be. So, in summary, we know quite a lot now about what is causing the antiphospholipid syndrome. We know what the antibodies target. We have an idea of how to interfere with it and how to use that in tests. There are many other groups, actually, who are looking at it in different ways. So, for example, there are groups who say, let's let the antibodies bind to beta-2 and look at what happens next to the cells. What is switched on in cells after that, and how can we target that? We're doing some of that work as well, but I'm not going to talk about it, except to say to you that the target I've talked about, domain 1, is not the only thing. There are lots of other things. And in fact, I gave a talk about this a couple of weeks ago at the British Society of Rheumatology, and I gave a list of about 6 different things which could all lead to new drugs for this condition. So I think, my belief is that in 10 years' time, I'll be able to point to these teacups, well, not these teacups, but other teacups, and we'll be able to say that we've moved along, at least to there, maybe even to there. Thanks. I'm going to have to go now. Do you need to take questions before I go? Because I've got to go and... Okay, yes. So I can't stay till the end because I have to go and catch a train. So if anybody has any specific questions for me, this would be the time. Okay. Oh, sorry.
You said it's beta-2. If someone has the LA,
Yep.
would this domain test also work on them?
That's a very good question. And the answer is that we... Yes, sorry. So the lady asked, some people have this test called the LA, the lupus anticoagulant test, and she asked whether they would also be positive for this anti-D1 test, anti-domain 1 test. This is something that we have to check on. What I believe is that not all people with LA will be positive for this anti-domain 1 test. I don't think that there will be 100% overlap. I think many people will have both. Some studies have shown that if you take the 3 tests we use now, the more of those tests you're positive in, the worse it is. So if you're positive in 1, it's not as bad as if you're positive in 2, which is not as bad as if you're positive in all 3, you see. So if you have this domain 1 test, what I'm hoping is that you can bring that in as a 4th test, which will help you even more to predict what's going to happen. So some LA patients will be positive, some will not. I hope it will give us more information so we can give more accurate predictions to patients about what will happen to them. Okay. So it's a good question. I don't think antiphospholipid syndrome is familiar in a simple way. So I guess the best way in which I can describe this to you is if I myself had the syndrome, I would not be terrified that my children would have the syndrome. I would say it would be more chance that they would be safe than they would have the syndrome. They would probably have more chance than my next-door neighbour's children who doesn't have the syndrome, but not a high chance. I wouldn't be killing myself about it. So I wouldn't routinely do any tests in my own children, but if they were to develop symptoms such as migraine or rashes and so on, I would be very keen to do the tests. So I would be guided by how they were.
Siblings have got it, and 2 out of 3 of my nieces have got it, and I can't. How do you explain it?
And I've met families like that as well, and you're right. Of course, there are some families in which there's a strong familial link, but the majority of patients don't have relatives with it. In my experience, Graham will have seen more than me. But if you imagine me in my clinic seeing a patient, and this patient is saying to me, I have children, how worried should I be? I might say that there are some families like your family, but I would also say that the majority of patients I have met are not in families like that. I don't know if Graham has a comment about that.
Well, when I was here before, I talked with Professor Hughes, and after the meeting, I had loads of families coming up to me saying, you're talking about my family.
Oh, right.
So,
well, you know, I probably have to defer to you and Graham on that, in that you may have seen more, but I generally tend to say to people the truth in my own experience, which is that the majority of patients I have seen do not have a strong family history. Thanks, very much. Perhaps you could just answer that question, because it is an important one, about whether the majority of people are familiar.
Yes, I think one of the problems is we don't ask the right questions. You know, that you have a sister with migraine or an aunt with MS, and these may all be APSs. So I think in the genetic side of things, we're a long way from answering that, because the clinical question has not been asked, actually. But anyway, Anisur, thank you very much. I've just promoted you to head of rheumatology at UCH. It's a great pleasure to welcome Lesley Regan, who's known to all of you, I think. She's the house of British television medicine, and is going to talk about the subject which is her own, which is pregnancy problems. Welcome back, Lesley.
Yes, it's wired up there. Thank you very much, and thank you for inviting me to join you this afternoon. Now, I've been asked to talk specifically about pregnancy loss, and what I want to emphasize to you is a very simple take-home message that I see patients with APS who are quite different from the patients that Munther and Graham see and that Anisur sees. So what I caught at the end as I came in to the last talk, I want to emphasize again and again, and that is the take-home message if anyone's feeling a bit sleepy and wants to doze off now, because it's quite simple. You have to be very, very careful which patient group that you're looking at in order to interpret the tests that you're doing and to advise them about how best to treat them. So I'm going to talk a little bit about pregnancy loss, and I want to start off. Can I take this out and walk around? I want to emphasize to you that pregnancy loss is a spectrum. So some people get confused and they think that implantation failure or infertility is pregnancy loss, so that's been linked to APS as well, perhaps wrongly, but it has been linked. And then there's miscarriage, which is my particular interest, and miscarriage, which just means the spontaneous loss of a pregnancy before 24 weeks. And it can be divided into sporadic miscarriages or recurrent miscarriage. And the importance here for me to emphasize to you is that it's the women with recurrent miscarriage. I'm going to get a crick in the neck if I stand up there. It's the women with recurrent miscarriage that are linked with the phospholipid syndrome. And once again, it's really important that we ensure that we are all talking about the same thing. So if we're defining recurrent miscarriage as 3 or more pregnancy losses, and that's the definition that I'm using, and the definition we tend to use in the UK, that problem affects about 1% of couples. If we define it as 2 or more, then the problem affects 5% of couples. Now, 1 and 5% may not seem a big difference to you, but actually it means the difference between investigating 1 in 100 couples who are trying to have a live baby and 1 in 20 couples who are trying to have a live baby. And not surprisingly, the difference between having 2 or 3 miscarriages really does change the emphasis on what the underlying cause is going to be. So if we investigated everybody with 2 or more miscarriages, we wouldn't find that many people with APS. When we investigate them with 3 or more, we find about 15 to 20% of them have APS, and that's a very important one. Now, relevant to a talk about pregnancy loss, I think, comes from our understanding that actually problems in pregnancy are on a spectrum of disorders, and that just as important as the miscarriages early and the miscarriages late in pregnancy are those late pregnancy complications such as growth restriction and preeclampsia and preterm delivery. And so this very simple chart, I think, summarizes it all. One bar chart just demonstrating that the problems in pregnancy are a spectrum which may start in the first trimester with first trimester miscarriages, go on to be second trimester losses or late pregnancy losses or early preterm deliveries and stillbirths, and then third trimester complications. But, and this is the important bit, they all have a common etiology or a common blueprint at the time of implantation. So the quality and the depth of the way the placenta implants in early pregnancy determines whether you have an early miscarriage, a late miscarriage, or whether you go on to suffer a baby with growth restriction and preeclampsia. Now, I'm generalizing a bit, but you get the concept that it's a spectrum that we need to be really concerned about. And as I mentioned earlier, there's a difference between sporadic and recurrent miscarriage. I don't need to go over that. But the other point I want to emphasize to you, and it's particularly relevant, I think, when we first started looking at APS in recurrent early miscarriage, is that miscarriage that we see or declares itself is the tip of the iceberg. And that underneath the surface of the water, there are large numbers of subclinical pregnancy losses that we never used to know about. We're much more aware of now because, of course, most people carry home pregnancy tests in their bathroom cabinet. They don't have to wait for 8 weeks to go and see the GP, or in my mother and grandmother's generation, they had to have 3 period misses before they were even thought about as being pregnant. Now women will screen themselves on day 26 or day 27 of a cycle, and when the little pink or the little blue line, depending on what you've bought, comes up, they know they're pregnant. So large numbers of pregnancies that are underneath the surface of the water. So the problem is a large one. And the other point that I wanted to emphasize to you is that women who present with recurrent pregnancy loss are a different group of women reproductively from women who have had normal pregnancy outcomes. So this is a study that was done by one of my research fellows who's now my consultant colleague, and it was done a long time ago, as you can see, over 15 years ago. But what she did was she looked at all the women who were presenting to the clinic, and we're looking here at 500 women, and of course all of them had had 3 or more miscarriages, because that was the referral criteria by which they came to us. But then look at all these other problems that they had. Nearly a third of them had problems getting pregnant. They weren't infertile because they'd come to the miscarriage clinic, but they'd had problems getting pregnant, and many of these problems were ovulatory problems. And a very large percentage, about a fifth of them, had had a late miscarriage as well as their early miscarriages. Now, that figure of 22% may not seem very important to you, but if I explain to you that if we take all the pregnancies in the UK this year, only 1% of them will be late miscarriages. So this figure is dramatic. And of course, you won't be surprised to hear me mutter as an aside that many, many women in this group of late miscarriages had phospholipid syndrome. And then if you look down here, they had higher incidence of ectopics, terminations for abnormalities, and very importantly, a lot of the women that I see have had a live pregnancy in the past and then repeatedly miscarried. But interestingly, if you look back into that pregnancy, a very large percentage of them have had the complications. So if you go back to that previous slide where we looked at these late pregnancy complications, they'd had a live birth, but they'd been complicated by problems in the mother, such as preeclampsia, or problems in the baby, such as growth restriction. So if you look at a textbook that talks about recurrent miscarriage, they give you this sort of checklist of the possible causes. And for the purpose of today, in the next few minutes, I'm just going to talk about this group, the thrombophilias, which is a relatively newcomer to the checklist, and emphasize to you, take-home message, that phospholipid syndrome is the most important treatable cause of recurrent pregnancy loss at this moment in time. So here's the syndrome, and I'm sure that the previous speakers have defined it, but I, of course, am emphasizing it's the recurrent miscarriage that presents to my clinic. I very rarely see women who've had a thrombosis, even if they are phospholipid positive, and I rarely see people who've had, or women who've had thrombocytopenia or have it. So again, emphasizing my first point, it really is important to understand where the patient population is coming from. And you know all about this, the prevalence, but I'm going to emphasize to you that about 1 in 6 or 1 in 7 of the couples who walk in saying, I've lost all my babies, they're going to have this syndrome. And this is an audit that we do every 2 years, and it comes out with the same figure of 15 to 20%. And these patients are very, very treatable if you can identify them. And I heard Anisur talking about the pros and the problems and the pitfalls or the caveats of screening, and they're no less applicable to the women who come with recurrent miscarriage. I would emphasize, though, that if I was in Dr. Hunt's clinic, or is it Professor Hunt now? Is it Professor Hunt now? She would probably be poo-pooing anyone with IgM cardiolipin antibodies as possibly not necessarily that important. Or perhaps she's not. But what we found in the miscarriage clinic is that women who have lupus, women who have IgG or IgM cardiolipin antibodies, all of them are at risk of miscarriage, and all of them are potentially treatable. And I think this understanding has been, and this treatment that I'm going to tell you about briefly, has been very successful and has led to us redefining the obstetric criteria that allow people or allow clinicians to be able to access testing. So we don't just confine it now to 3 consecutive miscarriages. We also suggest that we should screen women who've had an unexplained loss of a baby that measures or is bigger than 10 weeks size, i.e. late loss, and one or have had a preterm delivery before 34 weeks, which has been associated with very severe preeclampsia or placental insufficiency. So if there's only one pregnancy loss, but it's associated with all sorts of placental abnormalities, then we're suggesting that you should screen those women too. Now, how do we treat them? So if 15% of these miscarriage patients have got this problem compared to 1 to 2% of the normal population, and if there's a very high loss rate of these pregnancies in the region of, I would say, 90% in the first trimester, and the underlying cause is a thrombotic one, then not surprisingly, the treatments that were studied and became the ones that were most used are those that are anticoagulant or thromboprophylactic, should I say. And here I'm summarizing years and years of, and many, many clinicians' hard work in one simple 3-line slide. And in summary, as you well know, I think, aspirin and heparin therapy significantly improves the live birth rate for these women who present with recurrent miscarriage, who are found, 15 to 20% of this population with miscarriage, to have the phospholipid syndrome. And there have been a variety of studies that have been done, and they've all come up with roughly the same figures of a live birth rate between 70 and 80%. And when you consider that if you recruit women with APS and a history of miscarriage pre-pregnancy, and you catch every one of those positive pregnancy tests, you will find that 90% of them will miscarry without treatment. Now, the rheumatologists and the hematologists, when we first tried to publish that study, poo-pooed it and said, oh, no, it's not as high as that. But of course, if you're seeing patients presenting with a thrombosis or a neurological problem, or you're going to see them when they have registered in the antenatal clinic which is going to be after 10 or 12 weeks. And what our original studies showed back in the 1990s was that, in fact, by the time you've got to the booking appointment in the antenatal clinic, the vast majority of those miscarriages due to APS had already occurred, so they would have been missed. So I'm confident in saying that 90% of pregnancies were going to be lost. Now, this is the pregnancy outcome chart of the study that we did when we were first looking at the value or otherwise of aspirin and heparin. So here we've got the number of ongoing pregnancies up the y-axis, and along here we've got the gestation of the pregnancy in weeks, from 5 weeks when they declare the pregnancy to term. And all I wanted you to look at was the black line at the top, which shows the live birth rate when treated with aspirin and heparin. And you can see that it's much better than if they're treated with aspirin alone, and much better than if they've had no treatment, which is from the no treatment arm. But what I wanted to show you also was this lady who had spent years and years and years having very early miscarriages, was treated successfully, but went on to have this little baby, who happily is now a bonny 10-year-old. But at the time this baby was born, it was born premature, growth restricted, and the mother had crashing preeclampsia. And the point I wanted to emphasize was that although this woman was very happy with her outcome, as are many others of those patients, that treating women with phospholipid syndrome who present with repeated miscarriages doesn't always mean that it's a straightforward pregnancy. And indeed, many of their pregnancies are quite complicated. So when I say here pregnancy-induced hypertension or preeclampsia, I'm not talking about a little bit of high blood pressure. I'm talking about really severe preeclampsia that involves the intensive care specialists and all sorts of physicians. The caesarean section rate of nearly 50%, I think, is often due to the obstetrician's distress rather than the fetal distress or the maternal distress. But that's another study, but another discussion. But the point I wanted to emphasize is that what we've done is not get rid of the problem of the phospholipid syndrome, we've postponed it in pregnancy, and it's manifesting itself at a different point in time. But in summary, if we look at all the studies, and this is a meta-analysis that was completed some years ago now, if you look at all the studies and treatment options with prednisolone and aspirin, heparin, in a variety of combinations, we can conclude that using heparin and aspirin in combination improves the live birth rate by a factor of 54%. And I've never, in the 20 plus years I've been running miscarriage trials, never found something that's had that much of an impact. So, in summary, therefore, using this treatment, we can move the live birth rate from as low as 10% and an early miscarriage problem to a live birth rate of 70%, but with a caveat that we often have late pregnancy complications as well. Now, just briefly, and echoing something that I heard Anisur talking about when I arrived, let's look at that pregnancy survival chart once again. And all I want you to do now is to look at me drawing a line through at 13 weeks, which is about the time that a woman moves from into the antenatal clinic and assumes that she's now safe from having miscarriages, or certainly early ones. And you'll see that after that point in time, there's actually very little difference in the live birth rate. So the question that we started asking ourselves was, if this aspirin and heparin is having its effect here, what is it doing? Because if there are experts in the audience here today who know something about ultrasound in early pregnancy, they'll immediately be saying, well, there's something odd about this. They're using an anti-clotting or a prophylactic agent against blood when there's virtually no blood supply in the placenta at this time. So what is actually going on? And so in this little sketch, what I'm trying to show you here is a piece of placenta, the villi on the placenta, bedding into the womb wall, which starts here. And all I'm going to say, and I'm generalizing horribly here and summarizing many, many students or PhD students from my team and from the teams here as well, I know, and their work over the last 15 years or so. And what they've showed is it's not just about forming clots in the blood supply up here in the mother's blood supply, but it's about the way these phospholipid antibodies damage the very young placenta and damage the quality and the depth of implantation. So when you're phospholipid positive, you don't fuse the syncytium properly here, and you increase the cell death of those placental cells there, and you reduce the ability of the trophoblast or the placenta to invade into the maternal womb lining. So all sorts of other effects before you've even developed a, developed a blood clot in this vessel here. So some thoughts. So The actions of heparin then are not just anticoagulant, we know that that occurs too, but also the heparin appears to be a trophoblast or a placental salvage agent. It actually restores the ability of the early placenta to invade the mother's womb lining. It stops the cell death going on. It helps the hormonal production. And in addition, the more recent studies have shown that it actually has an immunomodulatory effect inside the uterine lining as well. More for another day. The one thing I wanted to just finish with was a plea to those members of the audience who have phospholipid syndrome and have had pregnancy loss of any sort, because we've been talking, and I've talked to Graham and to Munther on many occasions in the past about trying to find the funding to do a longitudinal study of women presenting with recurrent miscarriage, not with thrombosis and all of the other problems that may be associated with APS, but getting a group of those women who've just presented or made their first medical presentation with miscarriages and seeing what happens to them in later life. Because, of course, depending on where they've come from, they will get advice from hematologists, from neurologists, from rheumatologists, and they all say different things to them, because those clinicians have a background in their particular specialty, and they have, if you like, a threshold of anxiety about their particular complications that they see. So, for example, if I've come from a hematologist who's an expert in thrombosis, like Professor Hunt, she will probably be worrying about me needing anticoagulation or thromboprophylaxis on a variety of different occasions. Should that be the case for a woman who presents only with recurrent miscarriage? How do we know that she's going to have those problems later? And we don't know. So one of the studies that we wanted to undertake was a longitudinal study. We've always had to do it on the back of an envelope, or rather scratching the money together on the back of some other study. But why I'm presenting this to you now and asking you to think about encouraging people to get recruited to this study was that we've recently been funded by the Save the Baby charity for a couple of years to kickstart this, and I wanted to just show you what the provisional analysis that we did at the end of last year provided us with. Now, if you take a database of 12,000 people, which we have, and you have an APS rate of 15 to 20%, that's a hell of a lot of patients. So you'll see that this very small sample is just the tip of my iceberg. But we have analysed a 10-year follow-up for 186 women who presented with a history of 3 or more early miscarriages. And we found that they had a prevalence of about, well, they had 6% of these women over that 10-year period had a venous thrombotic event, compared to 0.3% in the general population. And all 10 of these women who we did in this brief snapshot of a survey with reported VTEs had an additional risk factor. Either they were pregnant again and hadn't been treated appropriately according to the guidelines, or they were postpartum, they'd been involved in long-haul air travel, or they'd undergone some pelvic surgery, or they had a previous history of thrombosis, and importantly, most of them had a degree of obesity. So the results suggest from this very small snapshot that all women with recurrent miscarriage and APS should be advised to modify their lifestyles to minimize the risk of future VTEs. But my concern here is that many of the women I see who come from all over the UK to our specialist pregnancy clinic are being told that they can't use contraception, hormonal contraception, they can't have HRT in the future. All sorts of other caveats are placed on them, and I'm not sure that at the present time women with a history of miscarriage alone, that we have enough information to be able to give them, well, rather enough knowledge to be able to give them really robust evidence-based guidelines about how they should live the rest of their lives. And since women in this country now have an average lifespan of 8 decades, it's very important, particularly I think in terms of the postmenopausal years when they're at a greater risk of all sorts of medical complications, and for many of them they want to use HRT. So I think there's an urgent need for our guidelines. So I would leave you with a plea to anyone who knows of anyone who's had phospholipid syndrome or APS presenting with recurrent pregnancy loss, would they please get in contact so that we can follow them up, so that in 5 years' time, if I'm invited back to give this talk again, I'll be able to say something really evidence-based and definitive about what we should be advising women who present to doctors with pregnancy loss and are found to have APS. What should we be telling them about how to look after themselves in their later years? Thank you.
Thank you very much indeed, Lesley, for a super talk. We'll also have questions at the end. It's a great pleasure to welcome Professor Beverley Hunt, who's been with our lupus unit now for a number of years. As you know, has particular expertise in the new drugs as well as the old. So, Beverley.
So I normally stand up and we do a two-way exchange, but this year I've actually got some slides because the new blood thinners are, well, there's a lot of data and it's better done with slides. And if you go to, I've just load them up. I don't know whether you know, there was a big press release yesterday from Lifeblood with Thrombosis charity saying that if you're sedentary and you sit still for more than 2 to 3 hours, you double your risk of DVT. I hope you're all having good fidget whilst you're sitting there. So here we go, the new oral anticoagulants. And of course, what we want from an oral anticoagulant is something that's safe and it works and it's convenient. And we have warfarin. There is no doubt it works. I think you all know it works, but we have major problems with convenience. And going to an anticoagulant clinic or having your own coagucheck is not convenient. And we have also issues about safety. Now, the issue about safety relates to the fact that we have, in medical terms, what we say, unpredictable pharmacokinetics. That means that if we all have the same dose of warfarin, we all get a different blood thinness. And as you all know, if you alter your diet, if you alter what you drink, if you alter your drugs, you'll also have to alter your dose of warfarin. And if you don't, you've got a risk of bleeding. So a difficult drug to manage, and we've got quite a high risk of bleeding. And when in the 70s, the low molecular weight heparins came through, which is dalteparin, clexane, tinzaparin, inahep, all the other ones. They were a major advance because they have predictable pharmacokinetics, which means that if we all got the same dose of clexane, we all had 40 milligrams, we'd all get the same blood levels. And they'd be the same in all of us all through the day, in that they'd all go up and come down. So we don't need to monitor. Terrific, but not convenient, because to give low molecular weight heparins through an injection. And they have a different set of side effects. So we're about the new oral anticoagulants, because they have predictable pharmacokinetics. That means that if we all have one dose of the tablet, we'll all get the same blood levels and they'll remain the same day after day, not affected by food, not affected by alcohol. And the magic words for me, fixed dose, no need to monitor, no trips to the anticoagulant clinic, throwing coaguchecks away. Makes me smile. And I think about the 1 million people there are in this country who are on anticoagulation, going to anticoagulant clinics. And there's real excitement because not only are they convenient for you, but they also look like they work better and they have a better safety profile. They cause less bleeding problems. So, do we have the prospect of the better treatment and better quality of life for you? Well, let's just look at them. You don't need all the techie stuff. I'll just give you the names. So this is dabigatran. This is the first one to come through. It's got a license in various areas, and it's being used widely throughout the world, but not so much in England yet. And it's derived from leech extract. You remember when leech is attached to you? They suck up blood and they anticoagulate you. So someone's taken that molecule, tweaked it a little bit genetically, and this is what we've got. And the one coming through just behind and catching up fast is rivaroxaban. And that's very similar. It works in a slightly different way. But again, the magic words are predictable effect, fixed dose, no need to monitor. And if we compare them, this is for medics, so it's a bit too much, but if we compare them, I just want you to look at onset of action. So warfarin takes days to work, which is why normally you start off on a heparin, because that works straight away. If you look at onset of action, rivaroxaban, dabigatran work within 30 minutes. Isn't that amazing? So you could take that after you'd had a blood clot and you wouldn't need to have injections until the warfarin worked. Yes, there are some drug interactions, but they're quite small and specific. They relate to drugs to treat people who have HIV and some of the antifungal drugs and some things like digoxin or whatever. Now, this is why I am so excited. This is looking at the benefits of warfarin versus other treatments in all the trials we've done. And it's a meta-analysis. And if you're on the left, it favours warfarin, and on the other side, it favours the other treatment. And just working through warfarin versus nothing else in patients who've got atrial fibrillation, which is a major cause of being on warfarin, warfarin's definitely better. Warfarin versus low-dose warfarin, well, warfarin's better. Warfarin versus aspirin and clopidogrel, warfarin's still better. Warfarin versus zimalagatran, which is the first new oral anticoagulant that came out 5 years ago and it was abandoned because it caused liver problems, about the same. But if we look at the bottom, warfarin versus dabigatran, dabigatran is better, and so is rivaroxaban, and so is all the other ABANs coming through. Now, why is this? This is the summary of the trial for dabigatran, where about 18,000 patients who had a special problem either got warfarin or they got 2 doses of dabigatran. And this is the rate of thrombosis in these patients. And you can see it's greater with warfarin. So that the rate of thrombosis whilst they're on the medication is really telling you how good the drug is. So the dabigatran was preventing more clots than the warfarin. But the really big and exciting news is that the risk of bleeding was so much less with dabigatran. So this is the rate of hemorrhagic stroke. This is bleeding into your brain, which can happen in about 1 in 100 patient years with warfarin. Really, really cut back with the use of dabigatran. And what we've got, this is just summarizing where we are with all these new blood thinners. There are lots of ABANs coming through. This is a huge commercial market. If you think 1 million people in the UK on warfarin, there are many more worldwide. Every big pharma company has got a drug. So rivaroxaban, dabigatran, apixaban is also coming through. We're doing trials here on adoxaban. And they're all doing lots of studies in lots of areas. So really exciting. Some of them have got a license. But in this country, we have to put all of our new drugs that get a license through NICE. And so we get held back by about 6 months whilst NICE look and check that the drug is safe and that it's cost effective. So the rest of the world, America, Canada, Australia, New Zealand, Scotland, the rest of mainland Europe are using these drugs, and we are hardly using them at all. Naughty nice, you want to say. But hang on. I've talked about the fact that they have a different set of drug interactions, but what's coming through, if you look at all the literature, is lots and lots of problems with bleeding. So the New England Journal is the #1 journal, and there's been running correspondence about patients who are on dabigatran, coming up to casualty. Maybe they've had some trauma, they've had a road traffic accident, they've been run over, bike accident, whatever, and the doctors in the accident and emergency department cannot stop the bleeding. What do? Because, would you believe it, all those trials, nearly 100,000 patients put into clinical trials, we've got nothing to reverse dabigatran. So this is the only data we have, and this is 12 healthy men, and they were either having dabigatran or rivaroxaban, and they tried to reverse the effect with prothrombin complex concentrate. That's what we used to reverse warfarin. And it didn't reverse dabigatran, but it did reverse rivaroxaban. And when we look at what the manufacturers tell us to do, if someone is bleeding on the new anticoagulants, there's huge advice, but it's all just good common sense for a doctor. There's nothing specific. There is no natural antidote. So I am saying to you, we are at the dawning of a new age. I would love you all to be off warfarin and on a new oral anticoagulant. But we're not sure what to do with you if you have a big bleed. So maybe those old anticoagulants aren't so bad. I'm starting to reevaluate, to think, actually, warfarin ain't that bad because we can reverse the warfarin if you are bleeding at the end of a needle, and you're reversed within a few minutes. Maybe it's right that we should let the rest of the world have a look at the new oral anticoagulants, and we can learn from them when NICE approve these new drugs over the next few years. So what are we doing in antiphospholipid syndrome? Because we need to have a look at them, and there is no data at all, nothing. And really, all of the trials have been comparing the use of the new oral anticoagulants against an INR of 2 to 3. I know most of the audience here know what INR of 2 to 3 means. Nobody has done a trial and knows what dose to use if you're running an INR of 3 to 4. It's never been looked at. And I would think most of the room probably running an INR of 3 to 4. So we're going to start looking at rivaroxaban, which we think is probably the best in antiphospholipid syndrome. Here at St Thomas's with University College, we've been sponsored by the Arthritis and Rheumatism Council, and we are very gently and tentatively going to look at safety. And I don't know who here might have had a deep vein thrombosis in the past, but we will be looking at patients running an INR of 2 to 3 who have antiphospholipid syndrome to see how they get on before we move on to very complicated patients or patients who run an INR of 3 to 4. So the last thing to say is, I don't know who carries an iPhone. Everyone seems to more frequently. Just to say there's some stuff out there. The first is this app you can download from the iPhone store. It's for doctors, but in it, it has a protocol for what to do if you go into hospital, you have antiphospholipid syndrome and you need an operation, what doses of low molecular weight heparin to switch to. And the other one is this app, which was launched yesterday as part of National Thrombosis Week. If you put iClot in the iPhone App Store, you get a load of information about thrombosis. Thank you very much.
Thank you very much, Carol.
Thank you very much, Beverley, and I'm sure there are many questions to come after that. It's a great pleasure to welcome my old friend, Munther Khamashta, who, well, welcome up on stage, and finally got to get married last year. So,
okay. Thank you very much. I have the remote, yeah? Thank you. I'm going to tell you about exciting time. We are going to do an international collaboration studies, not at St. Thomas's Hospital, University College, or Royal Free. It's more international than this. This is a dream. It's happening. We are about to start working on it, and I'm going to tell you about it and how this is started. It's called Antiphospholipid Syndrome Action, and we invented that acronym because every group around the world, they always have acronyms, and this stands for Alliance for Clinical Trials and International Networking, okay? So I'll tell you how this was really the birth of this grouping, how this happened. The bottom line, it happened during the 13th International Antiphospholipid Syndrome meeting. This is something that invented here at St. Thomas's Hospital. Graham Hughes organized the first two at Hammersmith. He called it international, and there were 30 people, but it doesn't matter. It was 30 people at St. Thomas's Hospital coming from all over the place to talk about antiphospholipid antibodies. The third meeting was in Jamaica and start growing, and now to these international meetings, about 600 to 800 clinicians come around the world to attend these meetings from different specialties, hematologists, nephrologists, internal medicine, rheumatologists, and so on, who looks after patients with antiphospholipid syndrome. So what happened during this meeting exactly? The organizer, which is a friend of mine, suddenly received a check, $10,000, just like that. We are not used to this, you know. We are not working with the pharma industry. Nobody give us money for nothing, okay? So she asked me, you know, how this patient sent us $10,000. To investigate more, see what she wants in return. There is no free lunches. I learned this a long time ago. So what happened, what became transparent, that this patient is not a patient, is her daughter suffered from antiphospholipid syndrome, very mild antiphospholipid syndrome, and she started asking questions to the colleagues in New York, what's the chance for my daughter to have thrombosis in the future? She never had thrombosis. She had only thrombocytopenia, antiphospholipid antibody positive, and she started asking questions. And the colleagues in New York, who are senior colleagues, couldn't answer. Said, well, don't know what's the chance for your daughter to have thrombosis, but take aspirin and maybe nothing happens. Said, what do you mean maybe? For how long this syndrome have been described? She said, he told her 25 to 30 years. He said, why you are not working together? She started asking practical questions. And she said, okay, when is your next meeting? And he said, in Galveston, in Texas. He said, okay, I'm going to help the meeting, but you organize a session called Clinical Research in Antiphospholipid Syndrome. She paid for a session for us to talk about clinical research, for international group to talk why, and she came to the session trying to figure out why the hell you are not working together. You know about this syndrome, but Graham Hughes does his things in London, and Roger Levy does his thing in Brazil, and Cervera does his thing in Spain. Why you don't work together? So during this meeting, now we understand why she donated this money. She's a very rich, wealthy lady, and she wanted to do good, all right? So she said, okay, analyze how you can work together, and review the literature, what's available, and see if you can work together once for the good for these patients in the long term, try to understand how we improve the field. So we had a lot of time. Why this happened during the meeting, exactly during the meeting, the famous volcano happened, so we had extra week there to discuss, not for a few hours. The session was 1.5 hours. We were stuck there for a week. I promise you that Graham escaped. The day of the volcano, Graham was flying. He never stayed 1 week for any meeting anyway, so he escaped. He's the last one to escape from that meeting, by the way. So we were stuck there for a week. It was a long time to discuss. So what we discussed, okay, what we know this. This is a major syndrome. My previous colleagues convinced you that. This is a well-established syndrome. You go to any textbook of medicine now, you have a chapter called Hughes syndrome, antiphospholipid syndrome. There's books around. So everybody accepts the syndrome. That's a major syndrome for recurrent miscarriages, late pregnancy complications, thrombosis, stroke, heart attacks. So we're not going to dwell on that. And there is some data. There is some data, clinical data and therapeutic data where, as Anisur said, we are in the middle glass there, but still, maybe the beginning of the middle glass. But there is some data. So we know that, livido-reticularis skin. What we don't know is a big list that Graham Hughes dwelled on about the brain, transverse myelitis. If we leave it to Graham, Graham will tell you the major manifestation of antiphospholipid syndrome is headache, okay? So headache is very common in the general population. I am sure he's right that headache is an important component, but there is no very good clinical studies to prove it. So why we don't work together and prove it once for good and start treating headaches properly when it's due to the antiphospholipid syndrome? What about cognitive disorder that Graham Hughes mentioned, the lady who didn't manage to drive to pick her daughter from the school because she didn't remember how to drive to the school? And this is not uncommon, very common. How common it is, we don't know. It's common because we are a referral center. Graham Hughes is known for that. Many of the patients come to see Graham Hughes because he's known for the antiphospholipid syndrome. But it's very difficult to generalize to the general clinic, neurology clinic, how common is this in a general district hospital, okay? So this lady who is supporting us for this project, she picked on this, saying, well, collaborate with neurologists around the world. I have the money, I have the power to help you. She's connected in the United States, and she can help us. So this is the first lesson we discussed with her and reviewed the data. The next lesson where she is interested because her daughter never had thrombosis yet. So we know these antibodies cause thrombosis, but not all the time. Some patients have the antibody, especially lupus patients, and only 1/3 of these lupus patients during follow-up, 15, 20 years later, develop thrombosis. The other 2/3, they never thrombose in their life. So why is that? This is a fundamental clinical question. If we can distinguish who is at risk of thrombosis and who are the patient with low risk, then we maybe can target those at higher risk and figure out what's special about them. And this is where really she's interested, this lady supporting us, trying to prevent, not wait for the clot to happen, not wait for the stroke to happen. Can we prevent the stroke of happening? So we focus on this. 70% of the patient in general have antiphospholipid antibodies and nothing happened over time. Now, Lesley just finished. I don't know if she's still here in the audience. She said, as obstetrician, she different patient that we see, Graham Hughes, myself, and David De Cruz at St. Thomas's Hospital. This is true. But many of her patients with recurrent miscarriages, they go on and develop thrombosis. Can we estimate the risk of this thrombosis? We have limited data to estimate that. But the truth is 50 times more than the general population. If you have antiphospholipid antibodies, previous history of miscarriages, well, 5% patient year. 5 of these 100 patients every year, they are at risk of developing thrombosis. And that's important. We know this. And we need to target this group of patients. And we do need to do something about it. It was mentioned to you that, I think Anisur Rahman in his answering some of the questions, that if you have 1 antibody, the risk is less than if you have 2. And if you have 3 antibodies that we routinely test, the risk is much higher. At least we know something. Very little, but we know something. That you accumulate more antibodies, the risk is higher. Maybe we need to target this group of patients. But this is new. This is new knowledge. This is 2011. It took us 25 years to figure it out. It's simple. But because we are not working together, still limited data. And this lady is keen for all the experts to work together. So what we do about this group, like they go to see Lesley Regan, or they come to us because we have lupus clinic, and they have antiphospholipid antibodies, no thrombosis. It was mentioned already during surgery. Be careful. These patients are at high risk, and they need heparin after the surgery. Stop smoking if smoke. Try to encourage them to stop smoking. Long-haul flight, to take heparin before long-haul flight. All of that sound good, and we practice this. And that, in fact, reduced the risk in many of our patients because we proactively move into this kind of things. But can we use drugs, okay? Yes, we over the years use drugs. And the simple thing to do in these patients, give aspirin. Do we have enough evidence that aspirin protect? We always give aspirin. Graham Hughes, David De Cruz, myself. It's a safe drug to take. It's, you know, if you have stroke, most patients give aspirin. Outside of the antiphospholipid syndrome, if you have heart attack, most patients take aspirin. Aspirin has been known for more than 150 years, 140 years, is a safe drug. So we give aspirin, but really, do we have evidence is protective in these patients to have first thrombosis? There's only one study, only one, believe it or not, and this study is small, showed there is no difference between aspirin and placebo. And why is that? Because they were really low-risk group. It was study done in New York, very low-risk group. They excluded, I don't know why, the kind of patient that Lesley Regan sees, obstetric antiphospholipid syndrome, recurrent miscarriages, strict control of cardiovascular risk, because we tell them don't take the oral contraceptive pill before long-haul flight, take heparin and so on. The very few patients had thrombosis during follow-up, and the follow-up was very short. So it doesn't answer the question, and still our practice is to give these patients aspirin. Can we go beyond aspirin? And there is data to suggest, at least in lupus patients, that if you take hydroxychloroquine, the anti-malarial, you can protect patients from having thrombosis. So this is where the APS action group is going to focus in the future, to do a trial focusing hydroxychloroquine based on the data available from lupus patients. We are extrapolating data from lupus patients that showed that if you have lupus and antiphospholipid antibodies and you take hydroxychloroquine for your lupus, the chance of thrombosis is less compared to those patients who are not taking hydroxychloroquine. So this data is available, come from the lupus field, but there's no reason it shouldn't work in the antiphospholipid syndrome. So what happened next, okay? We discussed all of that. We had, as I told you, because of the volcano, long time to discuss all of these issues in detail. She said, okay, I come from rich family. She confessed that. She has the millions of dollars that we need to start. And why you don't come to Miami? Why Miami? All right. She selected with her advisors in the United States who should come to this specific meeting to be organized in Miami, and figured it out why Miami, very luxury hotel in Miami, because she owns the hotel. Simple as that. She called that meeting breaking out of the box, and here is the people who met in Miami. Very, very selected, with the advice from the obviously colleagues working in the field in New York who looking after her daughter. And we met in Miami for the first time. It was 2 days heavy meeting, very, very heavy meeting, trying to see if we can work together internationally, once for good. And we managed to do that. And she invited people from all over the globe, as you can see, from Australia, from South America, from North America, Canada, and Europe. And the Miami meeting conclusion was that, well, the first meeting were 28 of us, to create network of international multi-center, multidisciplinary researchers. Multidisciplinary mean coming from hematology, obstetric medicine, from cardiology, from basic science, and laboratory physicians, to create international registry for antiphospholipid antibody positive. So to have database with blood samples frozen for research, basic research, to create a subcommittee on hydroxychloroquine, which I told you that we are keen to try hydroxychloroquine for primary prevention in this syndrome, and create other subcommittees to see what we can do together as a group. And this was the mission of the group. So we have, when you form a group like this, you need to have a mission in life, and it's to prevent, treat, and cure antiphospholipid syndrome associated clinical manifestation through high-quality, multi-center, multidisciplinary clinical research. So, and there is secondary missions and so on, but the primary mission is clear. And with this, she can lobby the government in the United States. This is the group now, the creation of infrastructure. So we have the infrastructures, who is who there. And we decided to have executive committee that take decision about this international collaboration. As you can see, I represent Europe with Pierluigi Meroni from Italy, and we have one representative from United States, two representatives from United States, one from Canada, one from Latin America, and one from Australia, Krillis. So this is working. We start working. We are currently lobbying the government in the United States with her. She is a lawyer herself. She knows who is who in the United States, and she's helping us in a dramatic way. So this is the website of the organization. It's already available. You can check it, and you see what our activities are. This is cut from a newspaper which hit the news in the United States that this group is working, is formed, and it's important. And what we did so far after the formation of this group, so we met in Chicago, the first, in Miami, so we met the following year in Chicago. We have annual workshop. The first one was in London, in our hospital here, and the next one will be in 2 weeks' time in Berlin, coinciding with the International European Rheumatology meetings. We have several teleconferences. We talk about this all the time. So it's really, we're spending time and effort to establish this, and it's happening. So major accomplishments that we are going to do a multi-center study for those who have anti-phospholipid antibodies, no thrombosis yet. So trying to prevent the first thrombosis, not to wait for the first thrombosis to happen. And we are going to have, as I mentioned before, database for patients who have antiphospholipid syndrome with the frozen samples with plasma and serum, and to study the DNA, like the lady said before. Is this genetic? We need to do a proper genetic study to answer really the question. She said several of her family members have antiphospholipid syndrome. Could be the case. It's not the common thing to have families with antiphospholipid syndrome, but it should be frequent, and some families should have that, and we need to investigate that properly. So the future direction, start recruiting for patients. We are filing for ethical approval. Nothing I can do, any study of this nature without ethical approval. We need ethical approval. New members is open, is not mafia. Okay, it started as mafia, started as a mafia connection, but this will be open now to new members, to Japan, China, to other members in Europe. It's not, it was selected group, but now it's opening. And a funding opportunity. She is very heavily involved in the government of the United States, and we will be involved in Europe and European Commission trying to secure fund for this collaborative study. Thank you very much.
Thank you very much indeed, Munther. I'm sure, again, there'll be questions there. Well, many of you, I know, have had insurance problems, travel insurance and so on, and it's been a very murky area, and it's a great pleasure to welcome Dr. Kevin Somerville, who hopefully will enlighten us about what we can and cannot insure for. Kevin.
Well, good afternoon. I said to a colleague before I left the Gherkin to come down here, maybe I should check the exits as I walk in so that I could... But just to give you some perspective, my background's in medicine, as you read from my CV. I'm not an advocate for the insurance industry. And where I think that the industry and our risk assessment is wrong, that's the reason they employ people like me, to tell them that it's wrong and set them in the right direction. Now, I know statistics are a difficult thing for some of you, but this is a survival curve. And if you start off with 100,000 people at birth, and then you follow them, this is actually what happens in terms of numbers as we go through life. And eventually, if you get to 120, there's none of us left. And we live with a terminal disease, and that's life. We all die eventually. And really, it's a matter of timing, where we are on this curve, what might happen to us that may take us off the average survival curve. Now, there's another way of looking at this, and that is to think about death rates. And this is what the insurance industry does when it's thinking about life insurance. Although it's called life insurance, it really should be called death insurance, but no one would buy a death insurance policy. So what you're doing is you're insuring yourself against the likelihood of death. And this curve just shows you the opposite of the survival curve, except that it's on an annualized basis. So it's the death rate each year for a given age. And you can see that up to the age of around about 60, 65, it's pretty flat. It's increasing, is increasing at a regular rate. But it doesn't have much of an effect upon this graph until you get to this sort of age, and then it really takes off. And the age that most people probably in this room are at is around sort of maybe 30 to 50. The mortality rate is around about 1 in 1,000 in a year. That's 0.1%. Now, if we think about 1,000 people, and there are probably about 100 people in this room, so let's multiply it by 10, and think about that death rate of 1 in 1,000, it could be this person here. So each one of these dots represents one person. It could be this person here that dies in the next year. But it could also be that person. And that's where the randomness of death comes in relation to insurance. Because if death wasn't random in this way, if we could predict with absolute certainty who was going to die in the next year, the people who are going to survive would not go anywhere near an insurance policy, and the people who are going to die would actually want to go and buy one. And it would be completely and utterly unaffordable. So it's because there is uncertainty. None of us knows when our time is up. On average, we can work it out, but individually, we can't. And this is what insurance companies are doing. They're working with the law of averages. Now, if we think about this death rate of 1 in 1,000, and we have 1,000 people in that insured lives pool, then if the payout is going to be £1,000 when that one person dies, whoever he or she might be, each person will need to contribute £1 into that pool so that when that individual dies over the course of the year, the £1,000 is available to pay the survivors, the dependents, the people who are the beneficiaries. And that's the way insurance works. It pulls the risk, dealing with this randomness, and then pays out when the event happens. And 1 in 1,000 really approximates to the risk that most of us would have. My risk, I know, is rather higher than that. It's probably more like about 3 in 1,000. But that's just the fact that I'm out of that 30 to 50 age group. Now, of course, we could be dealing with a pool of people who have a rate of death of something like 10 in 1,000, in which case it could be these 10 people. Equally, it could be any one of the green dots there. And we could then go to 100 in 1,000, and this is very, very high rates. And we're thinking here of people in their 90s in terms of the healthy population. Now, of course, that rate, that mortality rate, isn't the only thing that goes into a life insurance policy. There are a whole lot of other things, and you can see them here. There are guarantees and cost of capital. I won't bore you with them. So it's not just as simple as 1 in 1,000, everyone giving £1, but it's something like that. And you can see from this graph that mortality risk cost predominates. These other things are really on the side. They would be making up 10 to 20% of additional costs. So it's the mortality cost that's driving things. Now, when we think about insurance, there's a group of people who are put into what we call the standard risk pool. This is sort of the average group, if you like. And we can think about the average group in a number of ways. We can think about the general population. And in effect, you could argue this is the way the NHS works, that it's actually a general insurance for the whole population, not dealing necessarily with death, but dealing with health. And that we all pay in, irrespective of whether we're healthy or not healthy, what our age we are, and we take out of it what's required. It's a point of care and delivery service which is free at the point of care. But we can then start to split up, because I've shown you already that as we get older, the rate at which we die and the rate at which things happen increases. And it increases at an increasing rate. So it accelerates. So insurance companies, when we're thinking about voluntary insurance, break up that population, the general population, by age. At the moment, we break them up by males and females, but some of you will be aware that there is a gender directive from the European Court of Justice which is telling insurance companies that we can no longer make a distinction between boys and girls, and we have to actually treat them in the same way as far as the baseline cost of insurance is concerned. Great if you're a young male driver, not so good if you're a young female driver, and so on. We know that males and females are different, but the lawyers tell us otherwise. And then we can split them up, split by smokers and non-smokers. And basically what is happening here is that the actuaries who are looking at the event rates are saying, this is what happens, this is the event rate, the chance of dying for someone, for example, who's of age 40, who's a male and a non-smoker. And that is setting the baseline cost of the insurance for that individual based upon age, sex, and smoking status. But of course, what happens when there are people who are not healthy? How are they approached? Or people who have a dangerous occupation? Well, this is where underwriting comes in. And so the underwriters and the medical officers will look at people who have an impairment who are at risk from a variety of sources, there might be a base jumper, they might go hang gliding every weekend. What's the risk? Is there an additional risk over and above this baseline price that a 40-year-old male smoker, for example, might pay? And that's, of course, where the antiphospholipid syndrome comes in. Because there's a baseline price which is being quoted. The question for us is what's happening for people who have antiphospholipid syndrome. Now, the way that we approach this is we use an underwriting manual. And this is the first page of Swiss Re's underwriting manual. Now, Swiss Re is a reinsurance company. Swiss Re insures insurance companies, and as part of the deal, gives an approach to risk assessment to our clients. Might be Legal & General, might be Aviva, might be Friends Provident, or whoever. This is the predominant underwriting manual used by insurance companies in this country, in fact globally as well, and this is called Life Guide. And this is how big Life Guide is. This is a Mexican doctor who was translating the English version, because it's all produced in English and then translated into other languages. He was translating the English language version into Spanish. And to facilitate this, he printed it out. So this is the English language version of Life Guide printed out. Now, I used Harrison's medical textbook when I was at medical school, and it was about the size of that. So just to show you what goes into this underwriting manual and what's available. It's available electronically. It's not available in this way. There's just no way anyone could use it in this form. And so to produce something like Life Guide, we are doing something that's very similar to evidence-based medicine. We're looking at the evidence, thinking about how the risk works, and translating that into hopefully updated and valid guidelines on how to handle the risk assessment. And this is where someone like me comes in. This is what I do, is I think about how the risk works in relation to various impairments. So we'll do a review of the evidence, and we're really thinking here about what the prognosis is, what's going to happen in the future. Now, before, when I was working in clinical medicine, I'd be thinking about that, but I'd be thinking about treatment and trying to get people better. What I want to know is what's going to happen over the next 5, 10, 15, 20, 25 years, because insurance contracts aren't short-term. They're not like a motor vehicle policy where it's renewed every year. You buy a life insurance policy or a critical illness or income protection policy, and it's there for the next 20, 25 years. It's a very long time. So we have to get it right. We have to actually look into the future. And so we're thinking about probabilities here. So the emphasis is on prognosis. We think, what does this mean for risk assessment? And we've got to compare the baseline risk, what the actuaries are already pricing for, with what the additional risk might be. And we can split that risk up. Are there better risks? Are there risks that aren't quite so good? Can we determine people who are going to have a more benign prognosis with their disease by comparison with those who will not? And this is translated into underwriting guidelines such as Life Guide. And this is the proprietary underwriting manual which we have. We have reinsurance competitors who have their own that will give them to their clients as well. And this is the basis for an evidence-based risk assessment done by the underwriter or the medical officer. That is the underwriting process. Now, what proportion of people are put into the standard risk pool and what proportion are actually put through the underwriting process and given a risk premium that's a little bit higher, sometimes substantially higher than the baseline premium charged or recommended by the underwriter. And that's changing in the UK. Whereas, way back in 1999, something like about 93 to 94% of applicants for life insurance were put into that standard risk pool. The proportion has decreased, so that by 2011, when Swiss Re did its last survey, it's actually under 80%. And the reason for that is, to a large extent, pricing. There's been and market. The market has driven this so that the price can come down, because if you reduce the rate, or the proportion of people who are put into the standard risk pool, you're selecting out people, if you like, who are going to have a lower mortality. And it's chicken and egg here, because as the market has pushed the prices down, it's meant in order to match the event rate with the price, the insurance companies have been more and more stringent about how they do their risk assessment. It's just a fact of life. In fact, someone said to me the other day that life insurance in the United Kingdom is as cheap as chips. It's never been cheaper. We've got over the AIDS hump, all the scares that were there 20 years ago when insurance companies went crazy and put their prices way up. And now it's really, really cheap. Term life insurance is very, very cheap in the UK, if you can fit in the standard risk pool. Now, here we come to the rub. You start looking for evidence. And I thought, okay, I'm talking to people about antiphospholipid syndrome. I will look to see what the evidence is. And there's not very much about what the long-term prognosis is. And I found one paper, and I got the full text kindly sent to me. This is 1,000 patients, which actually on the scale of things isn't a great number in terms of thinking about how the long-term prognosis goes. And it's only 5 years. Most of the contracts that we are writing are 20, 25, maybe even whole of life. So, when you look at it, it looks a little bit on the scary side, and indeed some of the pictures we've seen already and tell us that actually there are bad things that happen to people with the antiphospholipid syndrome. And I think you will be more aware than that than I am. And what's interesting from a life insurance perspective, and we can talk during the discussion about other forms of insurance if you like, 5.3% died over the 5-year period. And this is the graph of survival. So it's about 5 to 6% have died. And if you work that one, and are there any ways which we can identify the good risks? Wasn't all that impressive. No differences in survival with a whole lot of things there. So in terms of splitting up the risks into better and not so good risks, this paper doesn't help us necessarily all that much. We're told that the mean age of entry is 42 years. And I was able to work out, you can do a bit of mental arithmetic, but it's actually a little bit more sophisticated. You have to do a geometric progression. But it's something like 11 in 1,000 dying each year over the 5-year period. Now, if I look at a general population, and 82% of this population were female, so I have to adjust for the gender, the general population rate of death would be expected to be something like 2 in 1,000 over the next year. And the expected survival is of the order of 99%. So this tells me that people with antiphospholipid syndrome are not doing as well as the general population. And it's something like this. 10 in 1,000. And when I do the mathematics, we end up with something in the right box. So we've got a rate of around about 10 in 1,000 dying each year. Now, people who are buying insurance are healthier than the general population, and so the background rate for the insured lives population is around 1 in 1,000, and the ratio of 1 to 10 is a mortality ratio of 1,000%, or 10 times the risk. Or if you like the excess death rate, the excess mortality is an additional 900%. These are the sorts of figures that we are dealing with when we're thinking about life insurance. How does this translate? Now, I really shouldn't be showing you this, and this is to be obliterated. I've slightly modified it, so I haven't given you figures here, I've just given you some ideas. But basically, this is taken straight out of Life Guide, because I thought you'd be interested, and I think we need to be honest with one another. But basically, if you're doing really, really well, and you haven't had a lot of bad things happen in the past, and over 2 years or 3 years, if you're a smoker, bad things haven't happened, yeah, okay, we will take you, but you'll have to pay a little bit more. But if you actually don't fit into that, then there's going to be a medical review. And a lot of people are actually not going to be accepted for life insurance because of these very, very high rates. It's just a fact of life. And with that, I'll stop.
We'll do the questions at the end.
Yes.
We come to the last speaker and then question time, and Dr. Lawrence is going to tell us about testing for INR and the kits that are available, something that's important to many of us here. Come on top here, actually.
Thank you very much. So, good afternoon, everybody. My name's Oliver from Roche Diagnostics. I look after, as you can see, point-of-care testing for anticoagulation. I operate across other areas of cardiology as well. Come here today to talk about patient self-testing for those on long-term warfarin and how that might fit into ABS as well. So, a bit more than I expected today, so I'll try and liven the presentation up a bit. So the history of CoagulCheck started at the very beginnings in 1994. It's had several designs since. And what you see on the screen there is the way it is designed today. So we've got a larger model which is quite prolific in secondary and community care. And we've got the CoagulCheck XS below, which is more in tune to patient self-testing and single patient use. So those attending secondary care sites may use the XS Plus, or they may use a laboratory technique depending on where you visit. So the CoagulCheck XS, as I've mentioned, it's more in tune to patient self-testing. It's standardized across all of our devices, meaning that the test technology is the same in both our meters. It's portable, a larger strip compared to our last meter, and the strips don't need refrigeration like our previous meter. It's battery powered, so you can put rechargeable batteries in the rear of it. And your first purchase would come with a lancing device, single patient lancing device, and a small pot of free test strips. So, suitability for patient self-testing. This is based on quite a broad brush of patients that might benefit from patient self-testing. Receiving long-term warfarin, quite a key to point-of-care patient self-testing. Reasonable eyesight and manual dexterity, it's very important. If you're looking to charge your own condition, it's got to be quite clear that you're able to do so with our machine. Desire to take an active part in your own healthcare, so changing NHS genders more about patient self-care and taking charge of your own condition. Convenience to check your INRs within range rather than having to visit the hospital environment or even visit your GP. It can often be more convenient to self-test. If it suits your lifestyle, so if you're a frequent traveller or a younger patient, it might be more suitable in terms of self-testing. And just greater freedom within your day. The most important thing, which is going to be quite a recurrent theme within this presentation, is very important to have support of your healthcare professional throughout the process of wishing to self-test. So it's not a decision that you should take directly between Roche and yourself. It should be a decision that's made through your supportive healthcare professional. So where the test strips are designed, we've got onboard quality control, so every result that's obtained passes through our onboard controls. That means we know that the strips are kept correctly, they're in date, and the meter's fully functional. So every result you get, it's important that you have quality control and it's provided to you every time. There are other controls that can be done, and these can be done periodically in support of your healthcare professional once again. You can apply the blood from the top or the side of the test strip, so it means that if you've got a patient or yourself, if you prefer to dose it on the side, it's just got more flexibility than the last model we had. Strips at room temperature and available through FP10 on prescription. So if your GP is looking to prescribe and you've got your support there, then that's the way they are available. So our meter, again, whilst having the controls in place, it's important that we have external evaluation. We pass through the Centre of Evidence-Based Purchasing by the NHS, which means that our meter's proven to have external evaluation in terms of its accuracy and precision in INR resulting. Oh, what's happened here? Oh, there we go. Just to run over the main conclusions of this report, it's quite an honest external report of our device, so it's not kind of propaganda provided by us. It showed the excess gave accurate and reproducible results, and it was an easy-to-use system. It indicates that the excess is suitable for near-patient testing and the monitoring of oral anticoagulation therapy for most patients. So you'll notice that the second part of our presentation will move into APS and CoagCheck excess. So the benefits of our meter, it's insensitive to heparin, so if you're being bridged from heparin, kind of post-DVT or just the process of moving on to warfarin, it is insensitive. It's accurate to World Health Standards, so RSI is 1.0, so to laboratory staff usually means that we're very compliant with World Health Standards. We've got a lot of data to support our accuracy and comparability to laboratory standards. So the main interferences is the road we're steering down. So main known interferences with our device, hematocrit levels outside the standard range, bilirubin, so any liver issues, patients heavily jaundiced, can be known interferences with the device. And the main touching point is APA, the lupus anticoagulant. So that's going to be the second part of the presentation where we move into more explanation around that. So the support and service we can provide to patients and healthcare professionals looking to adopt a model of patient self-testing. We can provide ongoing support via regional training specialists. We have a nurse advisor that can gather patients together as long as it's in agreement with the trust or the GP. And they can sit with the patient, they can do periodic reviews and provide any training help if it should be required. We have the CoagCheck Academy, launched a few years back now. It's an online training tool. So if you're looking to screen, if a healthcare professional is looking to see the eligibility of a patient to self-test, they can always use that as an initial tool to see whether they're capable in terms of the knowledge behind their own condition. We have local point-of-care specialists that operate across the UK, and we have an in-house technical support line should there be any queries with regard to the everyday usage of the meter. Another option available to you is what we call the Excess Connect. So within the model of patient self-testing, it's obviously important that your results are relayed to your healthcare professional. Depending on where you have your support from, some of them adopt the use of the Excess Connect, which is an infrared device, so you can download all the results of your CoagCheck. It can go into your laptop, so you can view your results over time, rather than having to look through the memory on the machine. But that can also be downloaded and relayed to your supporting healthcare professional. So it can always be relayed to the anti-coag clinic, as long as it's a supported format. So the second part, because I'm aware there's a few questions around the CoagCheck and the lupus anticoagulant. So I'll begin with the warning we have on our insert for our test strips. So if you're eager enough to look through our package insert for the CoagulCheck test strips, you understand that, say, the presence of APA, such as the lupus anticoagulant, can lead to prolonged clotting times, i.e. elevated INR values. So essentially you can, in certain cases, have an elevated INR result, so a falsely high result. So I think we will begin to break that down a bit and just provide you with some insight into our official statement on that. So BCSH guidelines of 2012 touched upon this area too. They talk about the majority of patients, over 95% of APS patients will have a normal PT time when a baseline PT is performed. When the PT is prolonged, the BCSH guidelines suggest that it may be falsely increased in certain reagents such as Innovin and Thromborel. Our CoagulCheck, the technology we use, is very similar to Innovin, so it has been proven that Innovin as a reagent can have some sensitivity towards patients that have lupus anticoagulant. It's quite important to make it clear that there are a known interference with lupus anticoagulant and falsely high INRs. Where the baseline PT is elevated, so before you're moved on to a warfarin anticoagulant, if it's known that you have an elevated or prolonged PT due to the lupus anticoagulant, it's suggested that an insensitive method should be used. So if it's found that the lupus anticoagulant interferes with your PT time, it's recommended to go through a technique that's insensitive to it, so a laboratory assay which is proven to be insensitive to that lupus antibody. The last part of it states that the devices should be used with caution for patients with APS. We'll go on to a bit about with caution shortly. And again, reiterating the point, it's very important to have healthcare professional support throughout this process if you're looking to patient self-test. So the guidelines actually go on to state that it's quite rare for patients to have a prolongation of their baseline PT. Obviously, the effect that in a patient, if it does have a prolongation on their PT, means that their INR values will actually come through higher than their true INR values, which means that your dosage would be adjusted downwards unnecessarily. There is a small majority of patients, according to the study, and by conducting a prior assessment through laboratory technique, you would understand whether that is true to your particular condition or not. Recommendations, therefore, from the BCSH guidelines are the baseline PT should always be performed. If it shows a prolongation of your INR, alternative reagent should be used in that situation. Even still, if there are problems identifying a suitable system, i.e. CoagulCheck, for control of your vitamin K antagonist, the use of a different assay should be considered. So it's always taken into account the fact that there are several factors influencing the decision to take on board a point-of-care device, such as the CoagulCheck. Roche's statement, I believe that this was presented last year to you too, so I don't wish to kind of go over things constantly, but Roche's statement is that APA, such as lupus anticoagulants, are known to have an effect on the PT time, could result in falsely high INR values. Thus, where it is known to be present, it is important that a result be obtained using an insensitive technique. So it's important to initially gain a laboratory result using an insensitive assay, so one that's not affected by the lupus anticoagulant. There are many assays out there. It's important they use one that isn't sensitive to the lupus anticoagulant. We still recommend you use the CoagulCheck XS as long as they have existing specialist advice, so as long as you have the support there and you have understanding of your specialist so that they are aware that in rare patients, lupus anticoagulant can lead to a falsely high INR result, and that would be known at the very beginning of the process anyway. If a patient has a positive LA result, Roche recommend that they continue to have venous tests alongside the CoagulCheck XS for a period of 3 months, just so you can baseline check one against the other see if there is any variation there. And again, it's quite important just to reiterate, throughout this process, there will be a healthcare professional involved. It's always important to have their support. That's the utmost important thing. We don't wish for patients to go outside of that process, because it's extremely important. So, just to summarise, one reference which is pulled from the BCSH guideline, it's really important that self-testing is done in an informed approach due to the fact that there can be a slight chance that the lupus anticoagulant can have an effect on your INR. It's obviously known that there's many lupus patients here, APS patients here that are self-testing using the CoagCheck XS. But it's also useful to know that there is a known interference, and that is always displayed within our packaging insert. We do have the ongoing support from members of Roche, so if you wish for a training session to be arranged or any such advice through our technical support line, it's always available to you. If you do have any questions, always consult with your healthcare professional, and we can always relay communication that way. I'm sure there'll be a few questions at the end as well that we can always go over in the open forum, so I'm willing to answer anything then. If I can't, then I can just come back to you with a response. So, last point we'll touch on is just with point-of-care devices, it's always known differing results. So whilst lupus anticoagulant might interfere with an INR result in rare patients, there are also many other reasons why there might be a differing result when you baseline check against a laboratory technique. Most of these are just due to the sampling method, the pre-analytical techniques used. So getting a blood sample from a finger, you may leave it far too long before the blood's applied to the device. That will then affect your INR value compared to if it was side by side with the laboratory result. So it's always important to, especially when dealing with healthcare professionals, just to go over the idea that there will be differences between a laboratory and a point-of-care result, but these will be very slight variances. So it's important just to take that into account too. So thank you for your time. I'm aware I'm probably on the limit, so thank you very much.
Well, we come to the busy session, I suppose, the question and answers. And I know the acoustics are rather poor here, so obviously we've got a roving mic. And I'd ask all the speakers if they'd be good enough to come up to the front and help with the general discussion. Perhaps hands up any... right, the lady in the front, third row, second row.
My question is a drug-related anticoagulant. I've looked into dabigatran, and in the area that I live in, one of the criteria says that I have to be over 65 in order to take it, which then precludes anybody who is perhaps on the APS syndrome.
Is Dr. Hunt here? In that case, Dr. Khamashta is the expert.
In the antiphospholipid syndrome, as you know, is a young people disease, elderly as well, but young people disease, unfortunately, they're the most affected. This guidelines is not approved. As Beverley Hunt said, they are working on it for deep vein thrombosis and atrial fibrillation and so on. So it's still early days. So I think with time, we'll defend our space for the antiphospholipid syndrome once we prove it's safe. So give us the time. We're about to start, as Beverley Hunt said, the study, and we will be targeting young people. So he's going to be targeting people between the age of 20 to 40. So we'll have data in next year. I promise, by next year in the session, we'll have preliminary data. It's open study, okay?
Yes, in the front row.
I suffer with sleep disturbance, and I'd like to know whether that's related to my Hughes syndrome diagnosis. And I was wondering whether you're able to give any more information about the forms that sleep disturbance takes with Hughes syndrome.
Yes. The question was about sleep disturbance, and it's something that as just general doctors, we ask about, we don't go into too detailed, but in fact it appears to me quite an important and common feature in our patients, probably grossly underestimated. It's a new science. There is here a professor of sleep clinic, Adrian Williams, who runs a very good research unit, and I know that they've been studying a number of Dr. Khamashta's patients and Dr. De Cruz's patients. David De Cruz, can I introduce David, who runs with Munther the clinic?
I thought I might just contribute to that. So sleep disturbance actually is quite a big problem. I spent 3 years with my research fellow Colin Tench looking at fatigue in patients with lupus. And fatigue is incredibly common in lupus. It's also incredibly common. It's not been touched on this afternoon, but it's a very common finding when you ask patients with antiphospholipid syndrome, are you tired? Yes. And this is not just ordinary tiredness. This is severe tiredness. And the other aspect we looked at was sleep disturbance in patients with lupus. And this is, again, very, very common. There are sleep questionnaires you can hand out to patients. They fill them in. We don't understand why sleep disturbance is uncommon. They take longer to go to sleep. Their sleep quality is disturbed. They wake up frequently. The REM sleep, which is when you dream, is disturbed. So there's quite a lot of abnormalities which we don't understand. And I think, as Graham pointed out, the brain is a black box as far as we're concerned in lupus and antiphospholipid syndrome. We don't understand the mechanisms, but it is very common. And one thing that we did learn was that exercise is very helpful. It helps fatigue, and it also helps you sleep better. So one tip that, if you're fatigued, don't sleep in the afternoon, because if you sleep during the day, your sleep quality is affected at night.
Think of what Churchill could have done if he'd slept normally. Well, we've got a number of questions. Can I ask one on insurance, actually? One of the problems a lot of patients have is travel insurance, whether that you cover that or not. And to me, a patient on warfarin, well-controlled, INR beautifully, is a normal person and at no risk, probably the safest person on the aeroplane. Do you distinguish between treated and not treated?
This is getting out of my area. I also have adverse experiences of travel insurance as well. My current insurer is trying to reduce the age limit. The problem that you have is that travel insurance is sold as a commodity. It's a bit like buying a packet of cornflakes off the shelf in a supermarket. It's not like buying fully underwritten, risk-assessed life insurance or income protection insurance, or even health insurance for that matter. Now, who do you buy it from? You buy it from the travel agent. The travel agent knows absolutely nothing about what the risks might be. And the standard policies are just littered with exclusions. And you're really up against it. So my advice to you, and as I say, we aren't in the travel insurance business as a reinsurer, is to actually shop around. You may find, if you don't actually have your own group doing this for you, you may find people with groups associated with other chronic diseases who might be able to help you here. And of course, the biggest one that I can think of is diabetes. Yep. So if you actually go onto maybe the diabetes websites, the Diabetes Society, and have a look to see what they're recommending their people as far as how to deal with the travel insurance issue, which is a really big issue, because I don't think people who are chronically unwell should not be permitted to travel because they can't get insurance. I think personally, I think that's wrong. You will find that there are specialist people who will actually do the underwriting and what have you. But let's face it, you do have a chronic disease, it is being treated, and people are going to ask you to pay more for the medical aspects of your travel insurance if they're prepared to cover you. I think that's about all I can.
Thank you, that's very helpful. Hands up. Yes, gentleman here, then lady over here.
Hi. I'd like to ask a question about your dabigatran and the other one, I can't remember the name of it. That one. I'm currently under a cardiologist and have been checking my own ECGs. And I have got what appears to be atrial fibrillation and some other problems and probably some ventricular problems as well. Now, I know that NICE allow you to be on dabigatran if you've got atrial fibrillation. Now, bearing in mind my iron now I have to keep it about 4.5, and I'm still getting the thrombo, whatever you call it, on the veins, even if it's at 5. Yeah, especially if I've had a knock and that, it seems to trigger my veins to start to clot. You say that you're going to start a trial, but you only want people between the 9.5, 2 to 3 for this, whatever it is.
Yeah, the answer for that is quick, because the company is donating us the drug and they don't want to risk out of their license. Their license is for deep vein thrombosis. They didn't license the drug yet for arterial thrombosis or stroke prevention. So they are limiting us to give us the drug for free, which is Bayer. They are demanding it has to be only for deep vein thrombosis. Not this is my wish. No. My wish is to use it really in patients like you, where I am desperate to use alternative to warfarin, but they won't allow me to do it.
Because with me, the warfarin doesn't seem to work like heparin. I mean, if I could be on heparin, I can get away with far less heparin, and I'm much better. But I'm getting into problems with the warfarin. I wondered if, okay, you say there's a problem with bleeding and no reversibility in dabigatran, but surely, with my case, it might outweigh the fact that with warfarin it's not particularly working at the moment particularly well, and bearing in mind if I do have atrial fibrillation under NICE they say I can be on dabigatran.
In one word, all what Beverley Hunt said is 0 in APS. We have 0 data in APS. APS is exception. I have to go out of the box. Everything. If it left to me, you were an excellent candidate because I know you for dabigatran and rivaroxaban. But we need to do trials and safety data first.
It's quite interesting that we do have a small number of patients who definitely feel that heparin is superior to warfarin, and I think David and Munther are collecting a series. I mean, a Guinness Book of Records, I think it's been 4.5 years on heparin, living a normal life, except that she's like a pincushion. A question over here.
Yes. We've had an awful lot today about people who test positive for antibodies. I'd like to ask, what about all of those people who are have all the clinical symptoms of APL, and but actually test negative to the antibodies? Are we going to get left behind with all the research and left out?
Thank you. It's a very important question. Perhaps I'll ask both David and Munther to answer that.
We have a special interest. Graham Hughes and myself, we have special. We always look out of the box. You know, you are the small number of patients. The majority of here are seropositive, what we call seropositive, because they have the antibody. But not only you, many of you, I was able in 1 year to collect 100 patients and do some research. The truth is, these antibodies are there, but not the classical antibodies we look for, lupus anticoagulant, beta-2 glycoprotein 1, and anticardiolipin antibodies. 25% of the patient have different antibodies that routinely we don't look for. So we are looking for new markers, and the research is in progress, but it's so-called seronegative. It's not seronegative. You have some sort of antibodies, but not picked up routinely. So we don't ignore you, believe me. Other specialists might, because they follow the books. We always look outside of the books.
Yes, I think that's right. I think the science is lagging behind the clinical syndromes. On another level, though, you could argue it doesn't matter. So if somebody's had 5 DVTs, they're going to be on warfarin forever. It's not going to change the management particularly. But when somebody's not had thrombosis and they've had headaches and migraines and things, then it does matter, I think. So it is an important question in terms of diagnosis and treatment. Yeah.
While you're taking the microphone, I've got 2 anecdotes about that. First of all, I agree that we treat you exactly the same. If you've got the syndrome clinically, that's what matters. And secondly, I've got a pair of identical twins who are not here today, both with full-blown antiphospholipid syndrome. One antibody is positive, one antibody is negative. And that says it all, I think. In the front, sorry.
Our 27-year-old daughter was diagnosed with temporal lobe epilepsy at the age of 14. And then at the age of 17, 18, at my prompting, she was tested for APL because I'm positive too, and she was tested positive. There's no monitoring of her whatsoever, nothing. We did come up to see yourself my husband had Bupa at the time. We saw you privately 9 years ago or something. Readings were quite significant. I'm sure you would have written to the doctor, but nothing. She's 27 now, and she's still got epilepsy, she's got memory problems, she forgets to take a tablet. So I just wondered, should somebody be doing something on monitoring her?
Yes, definitely.
Yeah.
And the temporal lobe epilepsy is coming up very frequently. It's just another brain thing, isn't it, really? That part of the brain's unhappy, and it's coming from the temporal lobe. And again, we have an epilepsy expert in this hospital, and we're trying to persuade them to study their large series. Anecdotally, she may even have improvement if she is treated with anticoagulants. And it answers a question that you raised, one of the speakers earlier, that the genetics, you see, if they did a family tree on you, they wouldn't ask about temporal lobe epilepsy in a daughter, probably. And that's what I mean about asking all the right questions in families. Yes, lady in the front, and then in the back.
My question's about self-testing. I've tested for more years than I can think now, about 7 or 8 years, and have the excess now, had the previous machine. When I was first diagnosed, Dr. Hughes, with you, I know I was positive on the antibodies. I know I've had blood tests where I haven't been positive, so there's obviously some coming and going on that. When I do my own testing, I know my INR varies wildly. You're talking about a false high INR test if you have the LA antibody. Mm-hmm. How do you know whether you have it at that time? You know, if it comes and goes, how do you control that? How much percentage difference does it actually make to your INR, where I can be 2.4 one day and 4 the next, depends on my exercise, my diet, so many factors.
Good question.
I've tested for so long, I feel a little bit sort of gung-ho about it, which is probably slightly scary. But when I listen to you, I think maybe I should be a little bit more scared than I am.
Look,
I don't know.
It's a good question because, you know, interference is present with your INR. You know, like you said, diet. Warfarin is a very, it's full of interferences. So, yeah, I mean, yeah, there's going to be a lot of things impacting your INR there. It's probably very hard to pinpoint the exact reason for the variance you experience in 2.4 to 4. Obviously, Roche don't have great experience in the area of APA, and it's very hard to advise in any specific area, especially on an individual patient basis. I suppose I'm trying to skirt around the area here, but the research conducted suggests that the lupus anticoagulant will lead to, in some patients, a falsely high INR result. Falsely high, your dose will be adjusted downwards. I mean, there's no exact research to suggest the variance it will have in the INR. There might be professionals around me that might be able to advise from a prevalence point of view and what they see in patients, but it's quite tricky for us to advise. And you know, for patient A, the variance it's going to have on their INR result, because from a previous study, only 4.3% of those with LA actually had an impact when they had a baseline PT assessment. And yours is quite a complex case because you have the LA one moment and then you test negative the next, so it's quite a complex case. Of course.
Well, I think this risk has been overstated, actually, and I think that it's maybe being defensive on Roche's part to warn people, but it's put a lot of people off, and I think a lot of it comes from early studies by hematologists. A lot of it's mumbo-jumbo, actually, and I really do think we should largely ignore that statement, and I think Roche should get it out of their papers, things.
Lawyers. It's lawyers, Roche lawyers. To be careful, it's normal. You know, there is basic data to suggest this phenomena with the lupus anticoagulant interfering with the INR less than 5%, like your slide says. Small number of patients, but it's happened. If it happened to one of the patients using Roche machine, Roche will be in problem. So their lawyers have to protect them to put this in the prospect. Like you go to I run pregnancy clinic. Many of you know that. None of the drug has been tested in pregnancy in clinical trial to flick the coin and see if hydroxychloroquine is safe or not safe. The data suggests it's safe. But if you go to the formulary, say don't use in pregnancy. which is not logical to say don't use in pregnancy because the drug company will be responsible for the safety issue. So it's to do with it, similar to it, to protection. So it's like Graham Hughes saying, it's overprotection.
The lady in pink and then the lady behind.
I was wondering if I could ask about the connection with autism. I wasn't sure when you put it up on the slide if it was that families of patients with APS had autism, or whether there was a causative factor, a potentially causative factor.
Yes, I don't have any evidence to say there's a causative factor. In looking at families and getting a strong family history, autism has come up in a few of offspring. It may be that autism being very common, that this is just a noise level in epidemiological circles. But because, again, it's a possibly brain thing, I think somebody should be studying that. I don't know if I'm on my own in that. David?
Sorry, I'm being really naughty, but could I ask if there'd been any thing with schizophrenia? Because I know schizophrenia. Because I know schizophrenia and autism, there's a connection. I just wondered if
there have been some studies. It's not a big link. That's one good thing. Lupus patients can get psychotic episodes. Antiphospholipid, fortunately, not a major feature.
I'm just adding to that lady who was worried about her INR and the LA factor. And I have a venous every 3 months, and it's always exactly the same amount out. It's always 0.7 rather than any other. It's always absolutely spot on. So I gather that is where the machine is. So when it goes up, I keep it now between 3 and 4 because I'm fine there. If it drops below 3, I'm not. So I think it's a matter of how you feel, whether you're going to get a headache, and monitoring yourself. But I found even when I'm up very high, I can still have other things. I think maybe a little bit of damage has been there in the past, and I can still come out with wonderful words. As I did a couple of weeks ago, like having a look at sea batter on the way past on the train. And of course, getting looked at as though I was mad. And I say, sea batter, it's like a table with the 4 legs in the air. Large building. Of course, it's Battersea, and I don't know I'm doing it. And it still occasionally happens, but I've gotten to the point now where I can laugh at it. Yeah. It's something that's probably going to stay with me. But the actual amount that things are out, I think if you have a good nurse and you do a regular, say every 3 months venous, it does help settle things down.
And if your INR goes wrong or low, does the word finding problem get worse?
Yes. Yes, a lot worse. Thank you.
Hello. I'm on warfarin and my target range is between 3 and 4. Fortunately, I don't have any sleep disturbances, but even when my INR is between 3 and 4, I've realized that during work, daytime, I tend to sort of fall asleep, kind of a micro sleep. You suddenly fall asleep and you realize only when you wake up, and that could be like 2 or 3 seconds later. It doesn't happen every day, but once it happens, it happens very badly. So, it's very difficult to concentrate and obviously very difficult to work. Do you have anything to suggest that how could I improve that? And the second part of the question, are there any long-term side effects of warfarin? So just 2 questions, please.
I'll answer the second and ask David to answer the first. Long-term effects, no. Funnily enough, it is one of the safest drugs, as Beverley Hunt said, and luckily it's unusual for us to have to stop it from allergy or whatever. We know of no long-term effects coming out of the woodwork. Its only effect is of the anticoagulation. But the sleep pattern, I think I'll pass that to my colleague.
It's very interesting. So Graham mentioned various forms of epilepsy, and there is a particular type of epilepsy called narcolepsy, which is where what you describe, you suddenly fall asleep, or what looks like falling asleep. You just have a blank spell. So that's something that might be worth bearing in mind. The fact that your INR is well within the range, maybe it's something different. But it's something maybe we could talk outside. I don't want to betray any confidentialities, but maybe it's something you ought to discuss with your GP and perhaps have a brainwave test and the EEG. So that's worth considering, I think.
I must say, I used to think that sleep clinics were a waste of time, but I've changed. I really do think that they can help people.
Yeah. Can I ask if it's known whether there's a connection between Capaxone, which is used for MS, which is a glatiramer acetate and warfarin, if both are used together, does one interfere with the other? Is this known, or?
I don't know. Can my colleagues help?
No interference, to the best of my knowledge. All the medication used for multiple sclerosis are allowed during warfarin therapy. This is what I can tell you. There is no interference to the best of my knowledge.
Okay, thank you.
Thank you. Thanks. Lady and gentleman first. David.
Except some of the treatments for MS, like interferon, some of the interferon treatments are known to increase the risk of lupus and cause exacerbations of lupus. So one has to be a little bit cautious with that aspect.
Hello. It says here that we don't know how antiphospholipid syndrome occurs. Does it actually ever go away?
No.
Question at the back.
The antibody might go away, but not the disease. You're still at risk.
One of the worries we've faced is that 1 or 2 patients who've gone negative, we have stopped the anticoagulant, and they've had another thrombosis. So we're very ignorant about what to do in that situation. As a gentleman, there's one at the back. Oh, sorry, here first, and then at the back.
My question is, I was diagnosed in 1990 and my case was published in the BMJ. I had a really good haematologist on board who said to me, don't stop your INR, even if you, don't stop your warfarin, even if you've got high reading. Sadly, he's now retired, and I had an INR of 8.5, which I know is really high. I was told to stop my warfarin for 2 days. It dropped to 2.2, and then I've had TIAs. I had an INR of 7.7 for some, I don't know why, but they're being erratic at the moment. I asked not to stop my warfarin, managed it myself, and after 3 days brought it down to 3.1, my concern being that I had INRs of 1.4, and I was told that I had fibromyalgia and I was depressed.
Fluctuation in the INR is very common in the antiphospholipid syndrome. We don't know exactly why, but it's an art to anticoagulate patients with antiphospholipid syndrome. I won't recommend 7. 7 is really high, and the chance of bleeding with every INR above 4, every time you increase the INR to 5, 4 to 5, the risk dramatically increase. And there is data in the basic hematology field. Unfortunately, Beverley Hunt is not here. Definitely 7, you will be at high risk of bleeding, which is the other side of the coin, rather than preventing thrombosis. So I will definitely not recommend 7. These are the patients that Graham Hughes said that we give them heparin long term, and maybe if your INR keep doing this, you are better off with alternative treatment, which is heparin injection every day. It's safer, but you have obviously bruises as well. But you have to consider that.
And what fibromyalgia and depression, that we hear that every day in the clinics, I'm afraid. A lot of our patients have got what we call Sjögren's syndrome, which is dry eyes, dry mouth, and muscle aches and pains. And the two go together, both autoimmune features. And those patients are almost invariably given this silly label of fibromyalgia, which is a cop-out. You know, the doctor stops thinking. Question here.
What can we do about hospitals that don't believe in self-testing? Leeds Authority don't.
It's such a big question, so important, isn't it? And this is maybe where the charity can do something, because sadly you're not alone in Leeds. I mean, there's dotted all around the country. It's postage, whatever that phrase is. And education, I mean, all of us spend our time doing GP meetings, doing postgraduate meetings. I've even spoken each year to the Nurses Society who do anticoagulant clinics. I get the impression things are improving there, actually, but still even the nurses in anticoagulant clinics often give our patients a hard time. I don't have an easy answer except sort of education. Maybe
The problem with the field is moving. I know you have interest here and you are selling coag-check machine. But maybe it's go to the museum in 5 years' time. I don't know. You will be out of job. You come and work with us. No problem. but there is nobody's going to invest really to improve these machines and the use of these machines, because the prediction, whether it will be good prediction or not, that the newcomers that Beverley Hunt lecture will take over from warfarin. There is question mark about the bleeding, the antidote, and all of that. But the market is so huge that very likely the number of patients will be in warfarin in the year 2015. It won't be 1 million British, will be few hundred or few 100,000, but not millions. So the market, unfortunately, for Coago check is not going up. It's going to go down. For the time being, how to handle that is case per case. With our help, with your consultant trying to GPs need a letter from the consultant to say, well, I am happy for your patient to be with monitored at home. This is what we do, but you know, it works sometimes. Most of the time, it doesn't work. My question to you: why you didn't push for the NHS to pay for the machine as well? Only the strips. Why not the machine itself? 250 pounds is not a big deal.
So a few good questions there. So I'll begin at this. Variance is going to vary from trust to trust, as you can imagine. Some of you here might be quite well supported in terms of self-testing. Others, Leeds and Croydon. There's a few areas where PST isn't always an option to patients, whether they've AF, mechanical heart valves, or selected patients with Hughes. So we do try and assist trusts if they're looking to adopt self-testing, and we do try and help patients, sometimes provide education to healthcare professionals on the benefits of self-testing. A lot of the questions often revolve around the protocols. You know, what is a trust to put in place to ensure that if a patient is to manage their own condition, how can it be a safe system? And a lot of it is a question of change. So you might have a consultant haematologist who might believe that the best way to manage these patients is through an anticoagulant clinic. The protocol is written where self-testing isn't included, and sometimes it's quite an uphill struggle to sometimes change that, despite new clinical papers in that area that suggests, you know, you can be 85% time and range. So it's hard, but.
There was one very last question. I know there's lots of hands up, but we've got tea cooking outside, so perhaps we'll give that.
Yes, these are two very distinct questions. The first one is, how do you, can you get APS through your family? Is it hereditary? And secondly, could it be through a blood transfusion? That's the first one. And secondly, I'm in contact with Roche at the moment regarding, they've changed my meter, my test strips, my chip and everything. And I must admit, I did drop a few names for today to get this, but basically, there seems to be an offset between the lab conditions, the lab readings that you get here, and the meter readings that you get. Normally they expect the meter readings to be higher by, there's a dispute between 0.3 and 0.6. Mine are all lower. So I'm at sea now as to how to take my meter readings from the Roche.
I think what we'll answer the last question by putting you two together over tea, if that's okay. But as far as your first question is concerned, it's not catching. It doesn't come from getting blood. I think we'd all have it by now with the number of patients we see. And it's not strongly genetic in the current phrase, that there is a weak genetic tendency, which is still unknown how strong or not that is. I hope that answers the question. I'd like to thank you all for coming, for the questions, but especially the speakers for a very interesting session, and hope we have a further discussion over a cup of tea. Thank you very much indeed.